Okay, hello everyone. My name is Dr. Shariar. I hope so all of you are doing well. So we're going to start our, the PLAB recall class. And as you can see, so there is a chat box. So I'm just, typing hello in the chat box. So if you can say also hello, I hope so if you can see that one, because this box would be useful for you during the session. All right, so you can chat easily in the box, and or some cases you can unmute and also ask. All right, so let's just go for a trial, and let's just see if everyone can use the box well actually. So I just wrote hello, so I want to see if others can do the same. Okay, let me see how many of the doctors have joined. Okay. I can see Dr. Dipanvita Dhar added, Dr. Khan Roman RT, Dr. Rubab I know, hi Dr. Tofik, okay, Dr. Tofik I know for a long time, Dr. Salma, Dr. Salma Ahmed Shumi, okay, Dr. Lamia I guess, all right. So that's wonderful to see. A lot of doctors have joined. All right. So make sure in the beginning, so there are certain options like you don't need to start your own video. So some doctor accidentally click this one, like start video in the Zoom, and they accidentally opened up their own video actually. So never on, try to on this one. Your own video will be, starting in that way. Okay. And there's a button called unmute. So this one you can also use the unmute one. All right. So you can unmute and talk sometimes. I'll give you the flow in that case. So when to ask things. So some cases I might turn it off if there is extra noise and things are coming from the outside. So some doctors sometimes forget to, mute their microphone. So some unnecessary sounds might come. In that case, I might turn off for all. Later, I'll be turning it on actually. And as you see, there is a chat box. So I think just 3 doctors mentioned hi. I just want to see that everyone can say hello in the box in the beginning. Don't worry, without wasting time, we'll be starting. Today we're going to do, I think, the November, because that's the most recent 2019. So 2019 is the latest one, right? Because we are just in 2020, so the 19 is our first priority to solve in best possible way. All right, so that's our plan for solving 2019 first actually. Yes, so the November one is a recall we have. It was quite a well collected recall actually, so we'll take some more time on that one to solve that one. And in the meanwhile, I'll be also give you overview of some recent hot topics, so which could be really really helpful for all of you. All right, now about starting, so how the class will be proceeding. Okay, so class will be proceeding like I'll be showing you a question like this. If you can see, I'll be showing you a question. Okay, like this is one of the questions. So the question will be displayed actually. Okay, so this is one of the thing. If someone can't hear the sound, you can log out and log in again and use a laptop. In that case, your mobile device might have some issues. So in that case, actually, it will be fine. I hope so, because it's first class. So sometime there might be 1-2 minutes of issues in the beginning, but I hope so. I can see most of you are quite expert. All right, so this is a good thing. So let's check one more time how many doctors. Okay, Dr. Shubhra, I know, I think from decades, I think. Okay, hello. Then Dr. Salma, Dr. Asim, Dr. Dipanvita Dhar, Dr. Khandukar Sadiqul Kader, Dr. Nasmus Sakib. There's a one doctor with the R logo. I think I'm not sure his name. If you can say in the box, what's your name? I think Dr. R. And another is Dr. RT. So 2 doctors, one is R and RT. What's your names, guys? Okay. Dr. Rubab, I know. Some of the doctors I also know. Yeah. And someone using a Galaxy Tab. I don't know the name. So maybe Dr. Galaxy Tab. Anyways, Dr. Noreen and Dr. Salma at the same time. Anyways, so these are the things. I think all good. We are all set. So if you all are ready, just say, yeah, so it will be fine. All right. I'm not sure. Yeah. So if someone is asking, not sure. All right. Yes. So yeah, we should say Bismillah. Yeah, someone said it's correct. All right. I think some of the doctors, will be fine. Yes. And also, if you see in the boxes, if someone might need little help, if you're a little familiar with the Zoom, also try to help your friend. Yes. So we are ready to go. Yes, with the first question. All right. Okay. Can you hear Dr. Shubro first of all? Okay. The normally is supposed to be fine. You can log out and log in that case. Log out and log in. You need to use laptop or desktop for better performance. Or later, if you can't, still technical problem. If you have from our side, no problem, because I think most of us can hear. Those are all are using laptop because it's a high density class. Always you should use a laptop first of all. So this is most important. Yeah. Then it's your problem, not our side. All clear from our side. You can watch recording later. All right. Or get a laptop. All the best. Okay, guys, so let's, without wasting time, let's start the class. So if I just add one, two thing, if those are having technical issues, they can't hear me. So for them, I'm writing one, two things. So if any sound issues, those are using tablet or mobile. First of all, you can do log in. I think log out, then log in again. It might solve the issue. Still, if not, you can later watch recording. Secondly, get a laptop or desktop, whatever. Okay, so this is the thing it is required actually. Yes, since first day, guys, sorry, my apologies for technical error for 1-2 minutes. And here we go. Here we start, guys. This is the first question. And for your kind of information, I can also take a timer along with this one so that you can answer the questions very nicely. So let me make it small. Okay, so this timer would be sometimes useful in terms of some of the questions that is given here. All right, so I'll read the question for you. So 27-year-old woman with redness around her areola for 4 weeks of duration, right? What is the duration, guys? 4 weeks of duration. Around the areola, you can remember as probably the nipple is involved. So nipple related disorder, it's quite common. She had used some antibiotic which improved her symptoms significantly. 5 ml of greenish fluid was aspirated from the breast. He smokes regularly. What is the most likely diagnosis? Now, guys, you have certain options. Always remember, when we are doing recall, the best answer always can be missing. Redness around the nipple means you can probably count. This could be something related to the nipple disorder, which you learned earlier. Now, something which is mentioned about the greenish fluid. This is one thing to remember. So what do you think, guys? What could be the answers? The quick answer. Remember always one thing, the best answer can be missing. Your time starts now. Okay, you can always answer in the box. Okay, so some went for E. I can see from the discussion. Some went for D and E. Some went for D as well. So D and E. All of you are in between D and E. Okay, so this is one of the thing, D and E. Now about this one, there's like two areas to consider. One that is it's mentioned about the redness around the areola. So a very popular thing is around the nipple and in the greenish discharge. So if we go for the next one, like uh, technically for this question, I repeat, technically for this question, maybe we can consider periductal mastitis, but that is not the main thing. There's a much better explanation of that one, and which probably can be missing from the main exam. So which I like to show you in one of the question which we have in 1700 band, which was like itching the breast and foul some discharge, like they specifically mention the nipple. So now it could be the recaller's mistake, because I have been conducting a lot of type of exam. So we know, like so nipple related disorder is a very popular question. And if there is any nipple related disorder, and sometime a synonym is used that near the areola, so probably they're also mentioning the nipple area and the greenish. So most likely in that case, now from this one, if you see, the answer is actually dark ectasia, right? So now what do you guys think? Like, now, what do you guys think about this one? So this one, even quite a similar question, but when you see the options, right? When you see the options, so probably B is the answer. Dark texture, like this is a perfect match. So since we are doing recalls are never perfect. Always do understand. Many time best answer is missing. So now two way we can discuss this one. Two way. So how you take note, guys? Like question number one, you can write like this one, and you can write a few of the explanation, because you all will be getting the file later through the Google Drive. So you don't have to worry. You don't have to take too many things. Don't worry at all. I'll be sending the file things. Okay, so you'll be fine, and also you will get class recording when the things should be over actually. But I'll try to send as soon as possible, collecting the your Gmails actually later. Okay, so with the available option periductal mastitis, but the best answer I still feel is dark ectasia. Okay, so if you guys have anything to ask about this one, feel free to ask me actually. All right. So I've given you flow. If anyone wants to ask me something, there's a box, and you can also unmute and ask me anything you want to ask. But main thing is the nipple discharge and the greenish. We start thinking as dark ectasia. If no doubt about my answer, then you can write move on. Okay, it is always important to you know um, yes, someone said it's correct. Greenish is mostly present in the ectasia. We understand the most probable one. Yeah, I think it's an easy one. It's not a big deal. This is an easy question. Yes, we'll be sending, don't worry at all. We'll be collecting Gmail and we'll be sending all of you. Yes, we'll be sending by Google Drive. So you can review it later actually, but it's not downloadable because some people share the file with friend. All right. So there's a more explanation of the same thing. There's more explanation. Why it's not periductal mastitis, like best answer is not, because there are few word which is supposed to be present. Now this is the second point I'm telling, and also hot to touch. So these are the extra word which I expect is supposed to be present. That is why the perfect answer is not the uh, periductal mastitis in this one. So if you see this question, you should know the difference between duct ectasia and periductal mastitis. So nipple discharge and only greenish, go for duct ectasia. When to go for periductal mastitis? When it will be mentioned about like probably young and tender and hot to touch. Right. That's some extra points. Moving forward to the next one. All right. Because we have to cover a lot of things. Gradually, I'll increase the speed. All right. Next one, a 20-year woman who is having a blood transfusion, has a pre-transfusional vital of this. Okay, as you can see here, pre-transfusional vitals are like this. All right, and for post-transfusion, start feeling unwell and vitals become like this. So can you see some difference? Temperature and certain other things, you can see some differences, right? So what is the most possible likely diagnosis? So 4 hours, it is said 4 hours. Now my first question, if I say the answer is this, is it correct? What do you think? If I say the answer is this, so I'm giving you guys 15 seconds to answer this one. It is not, because that will be immediate. In case of question number 2, if hemolytic reaction 1, if you are thinking, it should be immediate, but which is, in this case, it is said 4 hours. So this one is not a correct answer. So give a cross for that. So the remaining thing that is you can answer is non-hemolytic febrile reaction. Okay, so this one. Non-hemolytic febrile reaction, because the duration is after the 1 hour. So the cutoff value here is 4 hours. It's not a normal thing. Thank you. Next one, question number 3. A 40-year-old woman who has presented to the clinic with a 1-week history of multiple psychological symptoms like headache, abdominal pain, weakness, urinary frequency, and bloatness. Physical examination investigations are normal. What is the most likely diagnosis for her condition? You have, these 5 options, and your time starts now. Time up. Let's see the answers. Okay, many of you are answering E as an answer. All right. Now, what is the reason? Okay, without wasting time, let's answer why we think E is an answer. I also think, as like you, E is the answer. So since most of you are correct, I'm not getting into the 2-minute discussion, because the patient presented with multiple problem. Okay? So multiple type of problem they are mentioned. So that's indicating somatization. So there are sometimes some criteria are being mentioned that patient will be presenting with GIT symptoms, they will be presenting with neurological symptom, all right, there'll be some sexual symptom, and of course psychological symptoms. So there has to be some kind of combination of the symptoms actually. And there's another thing you will find, they are changing doctors. Every doctor they're going and just telling that the previous doctor, they didn't treat me well. So this kind of thing they will tell, and they will come up with prescriptions and a lot of other things. So that's high likely somatization disorder. Now, if I ask you one to think like, what could be the differential? Okay, what could be the differential diagnosis of somatization disorder? Because when you will go to the main STEM exam, you not only need to know the somatization, you also need to know the differential. So, what is another important differential diagnosis? Anyone? Yes, someone said malingering. Malingering, please do understand, there will be secondary gain. Malingering, there will be a secondary gain, right? So this thing will be present. So malingering, there will be secondary gain. Actually, there's another thing to. It's not only the stems. Hypochondriasis. This is one of the thing. Factitious disorder. In case of factitious disorder, they're just faking. Example: someone is taking, thyroxine tablet. Thyroxine tablet. Someone taking thyroxine tablet, and intentionally, even if they do the lab will come different. So sometimes they wanted to take, you know, uh, some vacation and all this kind of things. So this is one of them. So that is factitious disorder. Another thing it is said, Moonshine Syndrome or Moonshine Syndrome by proxy. Have you heard this kind of name? Moonshine Syndrome and Moonshine Syndrome by proxy. Anyone knows? You can unmute and also tell that one. What is Moonshine syndrome and what is Moonshine syndrome by proxy? Okay, Moonshine syndrome by if the patient himself or herself making themselves sick. That is Moonshine syndrome. Moonshine syndrome by proxy, example, a common scenario, the mother is making the baby sick and getting some more attention in the hospital. Okay, so that's the Moonshine syndrome. No, not for benefit. No, like that's the wrong conception. Moonshine anyway, not due to benefit. If it's related to benefit, it is going with the malingering. I repeat, if it is something with the benefit of the patient in any way, it's always going with the malingering thing. Okay, it's because actually they need some more attention and all these things. Yeah, this is one of the things to remember in case of the malingering. Secondary gain, this is one of the things. Factitious, usually no secondary gain. There's a word, usually. Yes. All right. We highly requested to use laptop device. Okay. And if you're using mobile device, please unmute your phone actually. Okay. Now there is a one thing, since I threw a question about factitious disorder and mentioned someone taking thyroxine tablet, is there any way to understand that if someone is taking thyroxine tablet just to make it fake? Is it a real problem or is that a man-made problem? Is there any way to differentiate? There is a way. Anyone? There is a way to differentiate. And that one is, remember one thing, T3 to T4. Now, if you can remember your physiology a little bit, which one is more active form? Like is T3 converted to T4 or is it T4 is converted to T3 for the final release? Anyone remember? All right, someone said is correct. So T4, T3 to T4. Everyone agree? T3 to T4. Okay. Now there is a ratio. Not many people know this one. T3 is to T4. T3. So the one that is probably in the blood and all this thing is mostly important. Like the preform, it is T4. So 1 is to 30 to remember. This is the normal. Please write it down. 1 is to 30. Okay, for a normal person. And in case of those are taking the thyroxine, intentionally making themselves sick. Now, T3 is endogenous. Will you agree on that one? T3, it is an endogenous secretion, isn't it? Endogenous means coming from inside. Now, if you are taking the drug, I mean the thyroxine, in that case, it would be 1 is to still 70. That will be 1 is to 70 still. Now T3 is not increasing because the one the person is taking, it is not related to disorder that is coming from the outside. So only T4 is increasing. This is not a case of T3 converting to T4, right? So this is the thing. That is how, if you ever suspect a case like this, you can go for a cross-checking T3 and T4. Most of the cases we do test TSH. What is the first line of test we do? TSH or T3, T4? This is a exam question, guys. What is the first test you want to check for a thyroid case? The answer is TSH. Next question, some of the quick questions is important. How to see the prognosis of thyroid disorder? How to check the prognosis of thyroid disorder? Again, the answer is TSH. Okay, again the answer would be TSH. So this particular thing to remember, the TSH is the initial test we do. Also to see the prognosis, we do the TSH. Later, if also it's necessary, we do usually FT4. So FT4 is one of the tests we like to do later. And also, if necessary, FT3. Another popular thing that often comes in exam is subclinical hypothyroidism. Subclinical hypothyroidism. Now, What you should do next in case of subclinical hypothyroidism? Do we treat subclinical hypothyroidism, or we like to investigate more? I mean later. Subclinical hypothyroidism. Anyone knows that one? So we'll do the investigation later. Okay. Usual cases, it is 3 monthly. Usually 3 monthly. Okay. So next checking is 3 monthly. And also is a very, very important thing to know what will be the parameter of the TSH, T3, T4. Now, T3 is always been a so important parameter. So in case of subclinical hypothyroidism, how to understand? Subclinical, that means patient does not have that kind of feature. But lab-wise, you will find few feature. Is it the typical hypothyroidism? Typical hypothyroidism feature means T3, T4 would be decreased, TSH is raised. How about in subclinical hypothyroidism? What will be the parameter? Anyone? Anyone remember this one? So someone said is correct. No, that's a wrong answer. So someone said low TSH and low T4. Is that correct? I think it's incorrect, Dr. Roman. All right. So it is decrease TSH, and this particular thing will remain normal. This is subclinical. Please never made mistake. This is gross error in the main exam. If you miss this kind of exam, I think questions, it can be a catastrophic accident. They don't want this kind of things to be ignored. Okay, Dr. Rahman. So this is very, very important. Okay, so Davidson has a very nice box in the beginning. So just take a note. Davidson, in the beginning of investigation of, I mean, in the endocrinology investigation, there is a nice chart given. Okay, so subclinical, clinical, there's a nice chart given. So please, those didn't go through that one yet, please go through once again. Thank you. Going for the next one. I hope so this will help. Next question. 29-year-old woman with sore throat has poorly controlled asthma on betamethasone, montelukast, salbutamol, salmeterol, and aminophylline. Has white patch on the pharynx, and that dislodges easily. What is the cause of her sore throat? Please always check. I have a thing. Usually, what I do, I check the first line. Many of you have gone through the IELTS, so now you guys know how to do this thing. So usually check the ages and 1 2 things, then check the last line, then just have a look on the question, that you'll get the idea. Oh, my question, I think, is something regarding this. Okay, so your brain is getting an information, from where to search the file. If you know where to search the file in your computer, it's become easy. Otherwise you have to search the whole computer. Now I'm giving you 15 seconds to answer this one. So there's a one thing given, poorly controlled asthma. So that is something to remember or understand here. So this is, I think many of you are answering correctly. So poorly controlled asthma and white patch on the pharynx that's dislodged easily. So what is the cause? Yes, that's a steroid. Yes, it's someone said it's confirmed. Yes, no doubt. So those have no doubt. We don't take that much time. Everyone understood. Just to add one thing, guys, here for asthma, never forget to learn about the steroid related side effects. Okay, and secondly, step care asthma management. Now, if I ask you a cross question, that means the cross question means while discharge, please listen carefully. This was one of the latest question as well. While discharging the patient, which one of the drug must has to be present in the discharge paper? The patient admitted 2 days back in the hospital with the nebulization and the current treatment, the patient become okay. Which one of the following must has to be present in the patient's discharge paper? So any drug suggest? So answer for this one is short-term prednisolone. So see, practical thing, Dr. Shubhra also knows. So some of the things are practical. No, must. This is must. Like, so see, your practical thing also is very, very important if you know. While discharging represent the one that is a life-saving must, guys. I'm also a respiratory physician. So must thing has to represent prednisolone lifesaver. Don't miss it. Okay. It's a lot of things. This is so important. No, salbutamol, why? Okay, salbutamol you can take any time. Like that's not the thing, but your patient is in danger. Okay, so you must have to go with the prednisolone and a 5 day short course. Commonly asked question like, is it having side effect in 5 days? Answer is no. With 5 days, 5 days treatment, there is no such, side effects. All right. So answer is prednisolone. So don't miss this one. And the stepwise care is very easy. Any book you go, Davidson's, John Murtagh, Oxford, very nicely given. So stepwise is a very small thing actually. All right, but you just need to know the pillars of. So more questions we'll see in the coming time. I'll be also guiding you. Yeah, because if I get into the asthma management now, it will take a lot of time. Okay, 6 year. Next question that is coming. 6 years with 3 episodes of urinary incontinence in a day. Ultrasound examination showing, I think, investigations are normal. What is the effective management? This is not a tough question, so I'm expecting a quick answer from all of you. Anyone knows the diagnosis, first of all? I check the first word, then check the what is the complaint, then I check, okay, I'm asking for effective management, and I saw the 5 steps. All right, so what is your diagnosis? This is coming first. I think most of you are correct, looks like. So anyone knows the diagnosis? I know you know the answer, but anyone knows the diagnosis? Okay, very well done. The thing is high likely aneurosis. All right, so start with, yeah, urge. You can say in a urge. See, urge is some kind of thing. It is not so common at this age group. Okay, someone who said, okay. See, urge incontinence. Let me tell you. Always check the age. So urge incontinence is not so common at this age group. Urge incontinence, how it will be presented? Say the patient can't hold urine for a while. I repeat, the patient usually can't hold urine in the bladder. So now a question is coming: stress incontinence and versus the urge incontinence, right? So in case of urge incontinence, how the patient presented, the patient complains they can't hold the urine. If they hold the urine, it's become painful. So like, in which case, like stress or urge incontinence, um, which one is painless and which one is painful? A question might be asked. So painful would be the urge incontinence. Like there will be a sudden urge to go to toilet. It is said here that 3 episodes of incontinence in a day. This is not, that much thing to be worried about. Okay, but if it would have been mentioned pain and can't hold the urine, so that would have been the urge incontinence. Now stress incontinence is even more common in elderly. So stress incontinence, how it is present because of weakness of the pelvic floor. Okay, so weakness of the pelvic floor. Now coughing and laughing. I repeat 2 words: coughing and laughing. Because when you cough and when you laugh, intra-abdominal pressure increases. I repeat, when we cough and laugh, intra-abdominal pressure increases, and that causes urine to leakage. So that is stress incontinence. So high L thing. Super important topic actually. Okay, so incontinence itself is very important. Incontinence, let me show you. I have something for you. Okay. So incontinence, if you see for a while, this one, stress incontinence, urge incontinence. Elderly, it can be usually middle age, but less common in child. We have to see the age group. And sometimes, as I was saying, never ever believe the recallers. High likely the question we were watching is a nocturnal aneurosis, high likely. So stress is elderly because of the menopause, the estrogen is gone. Because of the estrogen is gone, the pelvic floor muscles become weak. Now, what is the first line of management of stress incontinence? The answer would be, in that case, the answer would be pelvic floor exercise, which is also known as Kegel exercise. All right. Some cases, they want immediate effect. So immediate effect, you might get something with the estrogen, but eventually, if everything failed, you go for the surgery. So we should compare this thing. In both case, urge and the stress, ultimately what you are doing is probably failed cases surgery. Initial cases like the pelvic floor exercise. Now, even in case of urge incontinence, there is bladder training exercises that is also mentioned. Like same like in our one. Okay, so that is mentioned. But if you see the question, like if we come back and see the question, yes, I do understand. Many of us are thinking in the same way that it can be the urge incontinence, but do remember one thing, that urge incontinence very clearly mentioned it's a painful. And what do you think, the 6 years a boy or even a girl, what do you think, can they mention about the pain? Definitely I think they do. Okay, so there's nothing mentioned, so it can be a misleaded question. If they mentioned about pain in the main exam, so that is definitely then urge incontinence. All right. So initially, after considering all those things, we think it can be somewhere. Yeah, there is little confusion in this question. You think in this way that it can be stress, it can be urge. Stress very less likely in 6 years. Urge still can be, but it's also less likely. But more chances with aneurosis. Maybe the recolor has misleaded some of the word. Maybe recolor has misleaded some of the word. The high likely with this age group, as I mentioned, I'm conducting so many types of competitive exam. This type of question is almost always nocturnal aneurosis come. I personally believe the recolor has missed a word or something. So usually, if cases like aneurosis, we started doing urine RME. I repeat, we start doing urine microscopic examination. Why? Because often nocturnal aneurosis is associated with UTI. So the first thing in nocturnal aneurosis, always rule out UTI. Okay. After that one, this nocturnal aneurosis, or also known as the bedwetting thing. All right. So in that case, you need bladder training. Then there could be drugs, and there could be the alarm type of thing. Now, I told all my students one thing. This is a very, we all used to play games, right? And that's like a cheat code in the games. Like when you see the stems, you will also get some idea what is your question is about. Now, aneurosis alarm, why this one is coming, you tell me. Now, do you think this question related to urge incontinence after seeing the stems like desmopressin, which is the drug that is used in nocturnal aneurosis alarm that is used for the aneurosis cases, and the bladder training is the first initial treatment as a conservative we start doing, isn't it? All right. So this is one of the thing to remember. Now, still some cases, it's doubtful. Like, do we need to start the treatment? Actually, you should have asked me, doctor, if it's nocturnal aneurosis, and it is asked most effective management. There is a word, alarm, bell pad alarm is the most effective treatment. Then why you choose bladder training? Anyone has the answer of that one? Anyone having the answer? Why still bladder training? Yes, that's the thing. Also age group, like just 6 years. Okay, still we can try that one, and also high likely it's yes, daytime. That is true. Very well done. Very good catch, doctor. Very good catch. Daytime. It's mentioned daytime. It's not unlikely. Very nice catch, Dr. Fargo. Okay, so still the first thing we should do, bladder training. If say nocturnal, the typical one is I wrote here aneurosis. Often people say nocturnal aneurosis because the night one is counted, but actually the word is aneurosis. So some could be daytime, some could be nighttime. So for the daytime aneurosis, even more age group up to even 7 years is not a big problem. Okay, so just remember one thing. So you just tell the mother, don't worry, you just give the baby proper bladder training, the baby will be fine. Okay, clear everyone? The doubt is clear with the aneurosis, so daytime, nighttime, and when to use which one. Okay, new thing we learned, right? All right, moving forward to the next one. Like a lot of interesting question we'll be discussing in these 3 days. I think a lot of concept would be clear. No need to refer. Like, see, in those countries, we have, I think, a lot of GP. So though that is not a significant red flag thing to send the patient to a GP actually. Okay, if it's a significant red flag case, refer to urologic clinic. Not now. I hope so that will help you with the answer. Okay, new question. A 28-year-old female with 8 weeks of GA, gestational age, with 3 previous recurrent first trimester miscarriage, antiphospholipid to be present, and your management. So guys, please, I need a quick answer. It's not a very tough thing. You need to know the diagnosis first to tell the management. If you know the diagnosis, your management will be so easy. So thing is, this is a case of what? Antiphospholipid syndrome, which is an autoimmune disorder, and this is very bad. Why? This is very bad in terms of what? Recurrent abortion. Guys, please remember this term. Antiphospholipid, recurrent abortion. Antiphospholipid, recurrent abortion. Vice versa. Not vice versa, like similar actually. Recurrent abortion, so important. Lot of chances increase. Another thing that chances increase, not only recurrent abortion, another chance increases. And what is that? That is thromboembolic manifestation chance increases. 30 times, please write it down. Thromboembolic manifestation like stroke, MI, mesenteric ischemia, all this type of chances increased up to 30 times. So this is antiphospholipid syndrome. It is an autoimmune disorder though, but there is high likely it will be associated with a very problematic complication, miscarriage, and also it can cause stroke, most importantly. So we choose aspirin, and also the heparin. This is okay. Now this is an extra little line given. You know why this thing might happen. The reason this thing might happen because of like this is not required for PLAB really. Some of the thing like beta glycoprotein when binds with another beta 2 glycoprotein. Okay, so that holds the function of the platelet. So the job of the platelet get hampered because of this binding thing. Okay, so the platelet probably can't act well. This is some of the thing. So they will form eventually blood clot. So the thing that is happening, the platelet function get hampered, and so clump to form the blood clot. And if there is a clot form, you know the consequence. It can be stroke, it can be MI, this kind of dangerous thing. Moving forward. Okay, 38-year lady with giant cell arteritis. It has always been a very popular topic in PLAB exam. So always the giant cell arteritis, elderly, already we found a point with giant cell arteritis. Remember one thing, this is recall. So they might not tell you as giant cell arteritis. They will tell you elderly lady presented with headache. They might also tell you temporal headache. Second thing, they might tell you jaw claudication. And they might tell you another thing, ESR will be raised. This is how most cases I found the question. So one is elderly, second they will tell you headache, third they will tell you ESR raised, and they might ask you what to do next. Here they are asking you what medication to add. So this question might come as a diagnosis. This question might come as investigation. Most likely it comes as investigation. Like after ESR, what to do next? After ESR, we like to do temporal artery biopsy. All right. Now it's looking for a management. So what is the management we are looking for here? So high likely, the answer is yes. Yes. So high likely, bisphosphonate type of thing. Actually, mainstay of treatment. If I ask you something, this is not actually the first line. So they said additional medication. So you need to understand that one. Prednisolone things are mentioned already. So they said additional what you can do, additional bisphosphonate you can add. But without any delay. Now, a commonly asked question, I should give prednisolone or I should wait for the temporal artery biopsy report. What will be your answer? Give the drug or wait for temporal artery biopsy report? The answer is this is an emergency situation. This is an emergency situation. Do not wait. Without any delay, without any second delay, you give the drug. Otherwise, what will happen? What is the consequence of giant cell arteritis? That one I didn't tell earlier. Blindness. You don't want to lose the eye of the patient, so it can be dangerous. So blindness. Is it a reversible or irreversible? Another question is coming. Is it reversible or irreversible? Irreversible blindness. So you don't want to take chance. A short dose of steroid, no problem. But if the mistake happen, patient might lose the eye, you might lose the license. So this is the additional information, additional bisphosphonate. Moving to the next one. Now, few information is given here, guys, for all of you. As you can see, initially, without any delay, we go for steroid, which prevents the blindness. Yeah. Actually, to be honest, that we use so often, actually they don't lose a license, but there are some situation like fail to realize the condition. Actually, most cases you will get a lawsuit. Actually, NHS will protect you. That's the main thing. Okay, like some of the cases you intentionally get involved. Those cases, probably NHS will not stand for you. Okay, but if it's some of the cases which is possible for the NHS to stand for you, they have their own lawyer and thing, they will be fighting for you at the same time. Okay, it's not like this thing does not happen actually. You don't need it. Okay, it is asked additional thing. We don't want to get into the explanation. Okay, so most accurate biopsy of the temporal artery. Second thing is initial test is ESR. Initial test is ESR. Further confirmatory is temporal artery biopsy. Artery biopsy. Now I want to add something here among the lab. Have you heard this word, drug-induced myositis? Anyone heard this thing? Now, if I just add, I'm telling from my side this one. So ESR, along with the ESR, I'm looking for also CK, right? CK comes from muscle. Is everyone agreed with me? CK is something which comes from muscle. Everyone agreed? Yes or no? Yes. So myo means muscle. All right. Now, another similar some conditions I'm going to tell you, like um, polymyalgia. Have you heard this thing? Polymyalgia rheumatica. Rheumatica. Heard the name? A elderly lady who is trying to touch her shoulder because there's some shoulder pain and her ESR is raised. Polymyalgia rheumatica, high likely. Another thing, polymyositis. Cytis, also known as dermatomyositis, when associated with skin problem, also known as, but actually similar thing. Now you made some boxes like this, ESR and CK. Now let's make a table because often this type of question might come. So drug-induced polymyalgia rheumatica, polymyositis, or dermatomyositis. So drug-induced myositis, what will be your lab? Drug-induced myositis, say example, statin, say steroid. All of them are, many people don't know, steroid can also cause drug-induced myositis and it is even more common than statin, right? So my first question, drug-induced myositis, what is the lab? Because you have to depend on the lab as well. Answer is, which one is raised? Answer is Okay, let me take another color. I hope so, like if none of you are colorblind, you will see this one, green. My wife says you are a color blind because it's often, they came up with so many types of colors. Like, red has, I didn't know before marriage that red has also 10 more different color. I used to know red as red, but this is the consequence. All right. Now, next thing, as we can see, yes, so married people are on censoring. We all are, I think, understanding nowadays, like of different colors. Okay, so normal and normal. Please write this one. Drug-induced myositis, yes or normal, CK normal. Polymalgia rheumatic, I said, elderly woman who is elderly trying to touch her shoulder. So in this case, just write like this, ESR raised, but CK is normal. All right. See, poly and myositis. I remember in this way, poly and myositis. That means everything raised. Poly and myositis. That means ESR raised, CK raised. So polymyositis and dermatomyositis. So this lab will be given in your main exam, and you have to grab this lab. I usually answer this one from the lab rather than getting confused. All of them share a common thing. Can anyone tell me all of them sharing a common thing? What is that common thing is? Anyone? All of them sharing a common thing. What is that thing is? All of them having a feature called, no. I mean, clinical symptom wise. Have you heard this thing? Proximal muscle myopathy. Have you heard about this term? The muscle weakness in general. Now you give an example of proximal muscle myopathy, because in the main exam they won't tell you proximal muscle myopathy. They will tell that example. So a very common example, usually what not female doctors, all the female they do from the morning to the end. So what is that? So there's a common complaint, I think, by the patients. The doctor, I have problem, while combing my hair, because they do that so often, especially in case of boys. We are very straightforward, just one time, maybe maximum in the morning. Sometimes even we have duty, we don't get any time for even hair thing. So thing is, like, so the combing thing is very much evident in case of female. In case of male, buttoning the upper button of the shirt, okay, or getting up from the chair. So all these are example of proximal muscle myopathy. All right. So they will tell you in the question in that way. Okay, doctor, getting up from chair, I'm getting problem. Climbing stair, I'm having problem. Doctor, buttoning the shirt, I'm having problem. And also like combing the hair, I'm having problem. So these are the example of proximal muscle myopathy. You need to know the examples at the same time. All right. Okay, so another new thing we just learned, right, guys? Another new thing we just learned. Next one, we can move a little quickly. 4 or 5 questions, I think we can move a little quickly. A 54-year-old woman who is complaining of low back pain, which she was needing long time for studies, now complaining of her teeth being loose. So teeth is losing. This could be the complaint. On examination appearing normal. Investigation will best lead to diagnosis. You have 15 seconds to answer this one. A question related to low back pain and using steroid. It's a quite a straightforward question. So all you need to do is, well done, DEXA scan. So 54-year low back pain. Okay, so definitely we need these things. Teeth being loose. So we need to see the DEXA scan, also known as the bone scan. You can DEXA scan means bone scan. Okay, often for the cases like if you are losing bone, osteoporosis, this kind of cases, we can go and check the DEXA scan, which is also known as the bone scan. Okay, and often there are some scoring. I hope so you know that, guys. This kind of thing you must need to know. Anyone have idea about that? I hope so all of you already have the idea about the T scoring. Or should I tell you about the T scoring? Yeah, BMD scan. Yeah, same bone mineral density scan. That's correct. Everyone have idea about the T scoring? Or do you want me to tell that one? Okay. So normal, osteopenia, I'm trying to add that one. In our full course, we have discussed a lot of things actually. Some doctors, I think, lack of little short preparation, but it's okay. Hope for the best. So T scoring, you need to understand. First, let me tell you about osteopenia. Osteopenia ranges are -1. Remember one thing: the T scoring which is done for DEXA scan. Now you can Google it in future. How a DEXA scan report looks like. Its reports are in minus. So -1 to -2.5. That's called osteopenic range, and minus, I think, to like beyond -2.5. Yeah, beyond -2.5. Say example, if it is said in the question 2.8, -2.8, this is a osteoporosis. And if it is said like 1.8, -1.8, this is osteopenia. You got the point? Like that's how the T scoring is mentioned in the question. You have to pick up the T score, okay, and apply it. So what is the treatment, guys? Come on, like this thing is mandatory. Without knowing this can be dangerous for the exam. So osteopenia, what is the treatment? They will ask you in that way. So treatment is vitamin D plus calcium. What is the treatment of osteoporosis? Anyone? Alendronate or bisphosphonate. Alendronate, zolendronate. If osteoporosis and problem related to peptic ulcer, can I give alendronate? What is the side effect of alendronate? Actually, I can tell a lot of things about even osteoporosis. Regular class, a lot of things we discussed, I think. Quick question. Osteoporosis and peptic ulcer disease. What is the choice of bisphosphonate? All of them are under the bisphosphonate group. Yeah, so common side effect of alendronate is heartburn. I can't use alendronate if someone already having esophagitis. If someone is having bleeding peptic ulcer or active peptic ulcer, I can't use alendronate in that case. Right? In that case, I have to go for zoledronic acid. Zoledronic. Well done. Next one. The simple osteoporosis, I can talk about 1 hour actually. No worries, but it's a very, very important topic, guys. Read really, really well osteoporosis. All right. Even in relation with the parathormone, also read that one very well. Parathyroid hormone, parathormone, read very well. 52-year-old woman with disseminated renal cell carcinoma presented with dilated abdominal vein. So they already said the problem, and the problem is RCC, renal cell carcinoma, and some dilated abdominal vein. And this is something indicating, I think these informations personally enough for me. If there's a renal cancer, the cancer is getting bigger, the nearby adjacent structure, it also started to involve. All right. So the high likely chance, this is answer is inferior vena cava obstruction. No doubt, this is a straightforward question, guys. RCC commonly associated with IVC obstruction, please take note. And this is taken also from a index journal for more information. Yes. So can be associated with venous thrombus and this type of thing. And that particular thing can lead to inferior vena cava thrombosis or obstruction. If inferior vena cava obstruction happen, how do I get to know that there is a obstruction or this kind of thing? Actually, inferior vena cava obstruction thing comes less actually as a question. Actually, superior vena cava obstruction comes more. It's more evident. So you tell me in the face, how do I understand superior vena cava obstruction? I can do a CT scan, right? Will you be agree with me? Yes, superior vena cava obstruction, we do CT scan. But how do I get to know in the face, what is the face presentation of superior vena cava obstruction? Puffiness, not agreed. Not agreed. Anything else, guys? Redness. Okay, redness. I can accept. Redness. Actually, best word. You need to know the exact word what is given in the exam. Flushing of the face. I repeat. See, redness is a different thing, and there's another word, flushing. Someone said distended vein is a very nice word. I was looking for that word too. So superior vena cava obstruction, your jugular vein and thing would be, tortuous and things. So flushing of the face. There is a special test. It's called Pemberton sign. You turn the face to the opposite side and there will be flushing of the face. Why? There will be more obstruction when you turn the head. So that is called Pemberton sign. So just write this word. Next time you can Google it, like Pemberton sign. Okay. And it is also related to superior vena cava obstruction related to meiosis and anhydrosis. I'm talking about a condition. Let's see who can tell me the condition name. Supravenacle obstruction associated with ptosis, anhydrosis, meiosis. And that is Horner syndrome. But my question is not that one, okay? This one everyone knows. Which nerve root is involved here? I can take questions to any areas. Which nerve root is involved here? This is the exam question, guys. And of course, apex of the lung, the tumor can be involved. I repeat, apex of the exact nerve root, guys. C1, C2, C4, C5, T1 to T4, then L1 to L4. So which one? Yes. So two of them are correct. Simple chain and T1. Yes, T1 nerve root impulse. This is the exam question, guys. Okay, exam question. Next one. Okay, so some I think portion may be lost to above. Okay, so this was given. ECG showed T inversion on IV morphine and most appropriate next step. Okay, they're considering aortic dissection. Okay, they said it actually. Aortic dissection. What do you think? Okay, I'm giving you 15 seconds. Chest is clear, guys. Okay, so many of you answered C, some answered D. D is incorrect here. Okay, they asked next most appropriate step. Okay. Now my diagnosis is here aortic dissection. Everyone agreed? Dissection. So in case of aortic dissection, the next thing we plan. So stable and unstable patient. That's like two types. So this is high likely a stable patient. So in stable patient, we initially definitely like to go for an CT scan. Now, if I say gold standard, are you familiar with the word gold standard? If I say gold standard test for aortic dissection, which one? Is it a CT scan or is it the E1 like transthoracic echo? So in that case, the answer would be transthoracic echo. So next appropriate step they ask, next appropriate is I think definitely I have to go through CT scan, no doubt here. No doubt I have to go through CT. Next one, if you see in case of aortic dissection, so initially we can go for chest x-ray. What is the finding of chest x-ray? Anyone knows the exact finding? Guys, sometime for exam we need the exact word. Okay, I'm telling you, as we don't have that much time, mediastinal widening. What is the X-ray finding in case of pulmonary embolism? Very commonly given in the X-ray finding in the exam. They don't give X-ray sometimes, they just tell the finding. So in case of pulmonary embolism, that is wedge shape. Okay, please get familiar with these two terms. Pulmonary embolism, wedge shape. Mediastinal widening, aortic dissection. Carly's B line, guys. Carly's B line related to X-ray finding, which one? Heart failure. Good. Carly's B line related to heart failure. Consolidation, of course, you can understand pneumonia. So a lot of, or then there is Bilateral hilar lymphadenopathy, last November tested as well. Bilateral hilar lymphadenopathy in the X-ray. Of course, sarcoidosis. Well done. So anyways, let's come back. Initially, we definitely, stable patient, we can go for chest X-ray. Then definitely we go for CT scan. Okay. Later we can definitely go for that TEE types of test. Okay. This is a few extra thing we need to know. Few extra thing I'm looking forward. Number one risk, who can fill in the gap? Okay, let's not waste time, because if it have been other classes, I can give you much more time. Number one risk, hypertension. Number one risk, I repeat, hypertension. Initial X-ray. Best would be the TEE. But if first initial, then next would be CT angiography with contracts. Management. In case of management, if ruptured, then laparotomy. You have to open the patient. So unstable patient, go for laparotomy. Stable patient, you can monitor. Okay. I'm trying to give you guys extra information. So this is another thing. Aortic dissection. So as you can see, let's zoom in, guys. Zooming in now. So hypertension looks like the number one. It can be associated with Marfan syndrome as well. Extra point, guys. It can be associated with Marfan syndrome, a connective tissue disorder. So heart also has connective tissue disorder. So it can be affected. A CT scan of aortic dissection. This is called what? This type of one. This is called double barrel. This is kind of like a separation, double barrel aorta. Okay. Anyways, no worries. Going for the next one. A 65-year presents with a prior history of influenza, presenting with cough. So main features are here: cough and the temperature is a bit high. Bilateral cavitation. What is the diagnosis? So a condition which is related to the cavitary lung lesion. Your time starts now. This is an excellent question to put you guys in trouble. But you should answer this one correctly because it is possible. Okay. So cavitary lung lesion, there could be a lot of type of causes of cavitary lung lesion. We are choosing here Staph aureus, and the reason behind that one is this. So cavitary lung lesion, it can be infective, it can be neoplastic, means cancer, it can be autoimmune like Wegener's granulomatosis. Wegener's granulomatosis is a condition, who can tell? Wegener's granulomatosis is an autoimmune disorder which has two of the popular system that is getting involved. Two of the popular system that get involved. One of them is respiratory system associated with hemoptysis, and there will be renal involvement, the kidney involvement. So can be also presented with hematuria type of feature. Lung and the kidney involvement and autoimmune disease, and also often associated with nasal polyp. So this might be looking like lungs. Some might think this is as a nose. And remember, it can be nasal polyp as well. But anyways, infective causes are always quite common. Out of them, the bacteria, especially Staph aureus I'm taking. So my answer for this one is Staph aureus. Clear? All right, going for the next one. Women with 6-month history of amenorrhea. It will be very unlikely if you don't get a question from amenorrhea. So those of you have weakness in amenorrhea type of question, please read it very, very well. You will definitely get a question regarding amenorrhea. Okay. So patient is negative, physically fit. She is a long distance runner, or you can say marathon runner, whatever you want. and labs are given. Guys, for amenorrhea type of question, your lab is so important. I repeat. Now, you tell me one thing. Say if it is not given the normal ranges, usually ranges are given. Now, prolactin 600, is that high or is that within limit? Prolactin 600. Do you think, like I'm coming one by one, prolactin 600, do you think it is normal or do you think it is abnormal? Prolactin this one, yes, someone said it's correct. Prolactin this one, mild high is marginally like not significant actually. Like actually I was trying to tell there's two condition you need to know. Drug induced like prolactinemia. Please write this term. Prolacti. In short time. I'm as much as I'm trying to give you guys information, but many of you are attending the class. It's already from my regular batches. They know about these things. So prolactinemia, that means high prolactin level. It can be due to drug induced. It can be due to tumor. Now, how we can differentiate? If it is tumor related, your range would be more than 4,000, or some book says more than 5,000. It's actually the range I forgot. It's like nanogram. You recheck again. It's I think nanogram. And if it's drug induced, usually it's between 1,000 to 2,000, or even can be low. Okay, so these are the two things. Please, these are like cheat codes in games. Okay, but here the patient is negative physically fit long distance. So with a long distance runner where prolactin is fine, you see the estrogen and FSH. So this is, we also choose hypothalamic amenorrhea. Hypothalamic amenorrhea. Unfortunately, our Ricolar Bhaijan has forgotten the LH. I am 100% sure the LH was given too. Now, how do we get to know PCOS from LH and FSH? Is it possible? Let's see who can tell. LH, FSH, is there any ratio in case of? So something would be high. LH is to FSH, that will be 2:1. Some books says 3:1 as well. So 2:1, LH is to FSH. So nothing there. I think the our Ricolar Bhaijan has forgotten the LH, how much it was given. Okay, but normally it is supposed to be given. So we need the long distance runner, marathon runner. This is, I think, unlikely with PCOS. Usual cases, they are obese. I remember one thing: PCOS patients are usually obese, but there are a lot of thin PCOS patients I have seen too. And you have ovarian cyst doesn't mean you have PCOS. PCOS, you need to fulfill the criteria, right? There is a triad you need to fulfill for PCOS. What is the triad, guys? If I talk too much, please let me know. I just sometimes jump from here to there, right? But those are important to make the diagnosis. So one of them is menstrual irregularity. Second one, androgen excess, like hirsutism, a female who is having some kind of beard or mustachy type of thing. So that's like androgen excess. And third one is the cyst, like, is it a 3/4 cyst? Many female sometimes ask to the doctor, I have cyst, or I think I have then PCOS, there will be infertility. Is it true? The thing is, ultrasound showing at least 10 cysts, I repeat, ultrasound showing at least 10 cysts, then I can consider that one as, yeah, like the thing. Yeah, I'll give you a break, don't worry. Let me check the time. All right. Okay, I like to finish few more quickly. Then I can go for the break. Yes. Yeah, 10 minutes more, okay? Then we can go for a break. Yes, 10 minutes more. Okay, so the PCOS one, and you can see prolactinemia. I already told you, in that case, your prolactin would be more than 4,000 nanogram. Premature ovarian failure. Now, who can tell me, guys? As I mentioned, please let me know if I talk too much. So, because most of the topic I know actually taught at a certain point in my life. Yes. This one, at least you guys take a picture. Later you can at least see. I try to help you guys with this one. Premature ovarian failure, because I have seen question coming from this one as well. At least from the lab, if you see FSH increase, estrogen or estradiol decrease. Premature primary ovarian failure, FSH increase. In our case, is the FSH was increased, guys. In our this question, was the FSH increases? Answer is no. It was fine. It was probably fine. The FSH. So it's not premature ovarian failure, right? So this particular thing, so estrogen decrease, increase LH, increase FSH. That was not happening in our case. So it's not premature ovarian failure. I'll be holding here for 10 seconds. We'll take a picture. Okay. All right. Moving forward. Great. So we choose this one as hypothalamic functional hypothalamic amenorrhea, and here's some parameters given. Here's some parameters given. So FSH usually in normal ranges. Usually. Can be low as well, but usually in normal ranges. So you need to play with the labs in the main exam. Actually, thing happen, in our med school, we are not taught the lab in that way. So sometimes we get a little trouble with the labs. And some people are experienced with practice, so they're familiar. Yeah. So FSH, LH, and estrogen to be remembered. I repeat, FSH, LH, estrogen to be remembered. Any female who is presenting with infertility, what do we check first? That FSH, LH definitely we check, but we also do consider TSH, isn't it? Because the thyroid thing can also, hypothyroidism can also related to this kind of problem. Then what we do, we like to go for an ultrasound. After that, what we do, if still you do all those things and nothing significant came out, now ultrasound is done. After ultrasound, anything? FSH, LS, TSH, ultrasound is done to rule out the amenorrhea or even yes, like okay. One thing I forgot to mention in the beginning, if someone presented with amenorrhea, usually yes, pregnancy testing is mandatory. Good. Initial, actually, that's the first thing. Pregnancy test is mandatory. Just to cross check. After that, we know definitely you go for a FSH, LH to check whether PCOS. Then we go also check the TSH, the thyroid. All right. Also, we go for ultrasound. But another reason to check, what is that another reason to check, and what test to do for that one? Actually, let's not waste time. No, that's that's a direct bouncer. If you ever play cricket, especially in the 1D, you can't give the suddenly bouncer always. Yes. No, it will be expensive suddenly. MRI. We go for prolactin. Why don't we go for a prolactin first? Because the most common pituitary tumor is known as prolactinoma. I repeat, most common tumor in the pituitary is prolactinoma. Now, who can tell me what is the treatment of all types of pituitary tumors? What is the treatment for all type of pituitary tumors? I don't say prolactinoma. I said pituitary tumors. Remember one thing: all the types of pituitary tumor, the treatment is surgery, except for prolactinoma, where first line of management is drug. Okay, so another key thing. All right, going for the next one. Let's do 5 more quick, and then we go for break. 36-year-old lady with type 1 diabetes planning to get pregnant and is anxious about fetal abnormality. Which drug to be considered higher dose than the normal? So these are some of the so-so question without any delay. I think Yes, I think this one I should not explain anything. It's a so easy question, folic acid. Next one, let's see. A 97-year-old man, 7 days of reduced oral intake, increased confusion. So here is your some of the line. Confusion, dementia, pulse, and these are the findings. So skin turgor is decreased and sodium, potassium, you can see this thing, bicarbonate reduced, urea increased, hyperglycemia. So what is the appropriate fluid to give? I think in this one, the high likely answer is also given nearby. Hypernatremic dehydration. Actually, if you see the Davidson's medicine, I repeat from where to get this one's exact table and answers. Davidson medicine, there is a electrolyte imbalance chapter, hyponatremia. There's three types of hyponatremia and hypernatremia things are given there. So hypernatremic, a few things are given there as well. So here, the high likely our answer is also A actually. So it's referred to that table actually, the answer. Okay, let's finish 5 more quickly and then go for a break. Heavy smoker and alcoholic. Okay, so always there will be some hint in the question. So heavy smoker and alcoholic, having fracture femur, and third day of the admission develops confusion and nystagmus and hypertonia. What is the most likely medication to give? Classic question, guys. Absolutely classic question. First, you need to tell me what is the diagnosis. This is because of his, the alcohol he used to take. The alcohol he used to take. So delirium tremens. 48-hour crossed and he's not getting a sip of alcohol. So he's having now this kind of problem. Okay. Now it's a dilemma between actually which one to choose actually. Is it the IV thiamine or is it the chlordiazepoxide? Okay, someone said Wernicke's encephalopathy. That's also quite possible. That's also quite possible. But thing is, you see, it's a post-op case. In post-op case, Wernicke's is less likely. So your answer is probably not counted here. That Wernicke's can be, but this is not the exact time for Wernicke's. All right. Wernicke's, I'll show you a mnemonic. Okay, then you will understand some of the features present. But post-op cases, this is so common. So in your exam, you always remember one thing, the one that is more common, they like to ask that type of thing. So IV thiamine administered steroid. No, I think that's not the main thing. So IV thiamine is one of them, and chlordiazepam. Actually, both are correct answers. If you see the 1700 and things, both are correct answer. But which one is first? Like sometimes also glucose are given. So thiamine before glucose. So this time withdrawal cases, we also use that. The thiamine before glucose, but also in a lot of PLAB guideline, it's also mentioned chlordiazepoxide. All right. I choose the thiamine one. All right, so we choose IV thiamine. It's written, even if you see the Kaplan psychiatry, it's somewhere it's written. Even thiamine is something which should given first. Actually, I usually try to talk according to the books. Actually, sometimes there could be some of the things are mentioned in the question banks, but I believe the books are much more better references. So if I go with a book reference, I think I would choose the thiamine. And if I want to go with the 1700 bank, then chlordiazepoxide. But the thing is, chlordiazepam, like those are given the references by the students actually. So I believe more with the book one I should go. It's because I found that word, that thiamine first actually. It's thiamine even before the glucose and all other things. So I choose the A in this case actually. Okay. And one of the doctor was asking about the Vernix. I'll show you a very nice mnemonics or the Vernix. But as I mentioned, this is not the right time for Vernix because it's a post-op case. In post-op case, suddenly why? Because there'll be a lot of history for Vernix. And the patient, so this is one of the mnemonic I like to use. See, Vernix wears a reversible coat. You can see his coat is reversible. So reversible if treated. So confusion, ophthalmoplegia, ataxia. So you're looking forward to more symptoms, not only the nystagmus one, we're looking forward to more symptoms in case of Vernix. So Vernix wear a reversible coat. So CO and AT for ataxia. So the gait and things would be, affected. So confusion, ophthalmoplegia, ataxia. Next one, Korsakov wears a cap. Now confabulation, anyone knows the term confabulation? Is it lying confabulation? Are they lying usually? It's not like, it's like they're making their own things and they don't have control over it. It's like they're making their own stories, not lying, but they can stop telling, they just keep going actually. So confabulation, amnesia, so loss of things. So nothing mentioned also there. Also personality changes reported by the family members. Also not mentioned. Okay, so Korsakov carries a cap. So just remember one thing, the same person might be carrying a cap. So confabulation, amnesia, and personal changes. So do you like the mnemonic, guys? I hope so you will remember now this mnemonic. All right. So Korsakov and Wernicke's. These are the two nice mnemonic. You will not forget now. Whatever thing that will happen in case of Wernicke's and Korsakov, these are reversible. All right. So anything this is related to thiamine and this kind of thing, it is probably reversible. That's the thing. Okay, moving. Now a question related to 23-year with recurrent vertigo of 10 weeks lasting for a few seconds. What is the site of anatomical defect? What is our question related to? Question related to recurrent vertigo. For is letter for a few seconds. What is the site of anatomical defect? So I think I'm giving you 15-second time to answer this one, to think. So this is high likely. I think many of you are answering correctly. So this is semicircular canal. Guys, do you know how to differentiate the vertigo thing well? Like from the ENT side, can you differentiate different type of vertigos? Like when is BPPV, when is ventricular neuritis, vestibular neuritis, when is the cancer? Is it clear to you guys? Like because one question is confirmed. Okay, I'm telling. Okay, this one will help definitely. Okay, ready for bang bang now. Okay, all right. Firstly, all of them somehow related to vertigo. Okay, give a common symptom, guys. Just write this one. Give a common symptom, vertigo first. Now let's come here. What are the things usually they give in the exam and they try to make confusion? Migraine is given there, but you guys cut down the migraine thing because migraine, you guys know how to differentiate migraine. So I'm not getting involved with the migraine. Okay, otitis media, like the ER pain they usually mention. So these two is not a matter of concern to me. Okay, and usually they also don't bring this thing in the exam. Now, one of the feature related to ENT, please write it down. Deafness. Is it? Everyone agreed? Yes or no? One of the feature related to ENT disorder is deafness. Everyone agreed? All right. So deafness will help us here. Now let's see one thing. How many of this kind of condition is related to deafness? Let's figure out. Like ignore the migraine and ignore the last one, but how many of them related to deafness or hearing loss? So if you go here, yes, this one. So labyrinthitis also and vestibular neuritis almost similar. Vestibular neuritis and labyrinthitis almost similar. So most cases they give is vestibular neuritis, so it is not associated with hearing loss. Meniere's disease, on the other hand, which is sensory neural hearing loss, is associated with deafness. It is associated with deafness. Very, very popular BPPV, like when this, sleep and turn the head, the world is shaking. You're supposed to have a sound sleep and your world is shaking, how it feels. That's BPPV. Okay, and vestibular schwannoma, that means that cancer that's related to the cranial nerve aids, so sensory neural again. So that is also associated with deafness. So the summary is here: the Meniere's and the acoustic neuroma. I repeat, Meniere's and acoustic neuroma associated with deafness. So when you see the question, all of you have gone through IELTS or OAT. There is a thing, we do scanning and this kind of thing. So our eyes will looking forward to that deafness. If deafness present, your answer probably Meniere's or acoustic neuroma. If deafness not present, that means it's either between vestibular neuritis or BPPV. Everyone understood this one? How to crack this question. So Meniere's or that one. Yeah, I'm coming to those points, dear. No worries. I'm coming to those points of respiratory infection. So firstly, the word deafness. So my eyes will look forward to deafness in the main exam. So if deafness present, either it's Meniere's or either probably acoustic neuroma, right? If no deafness, is either vestibular neuritis or either BPPV. Okay, so we will stay in between that. Now the next thing is coming. How can we differentiate the vestibular neuritis and BPPV? Now, one thing will help, that is upper respiratory tract infection. And this one is here. The one doctor was telling, upper respiratory tract infection. This one, itis, infection. So often started with flu. After that, your immunity is suppressed, and then you get involved. So history of upper respiratory tract infection or history of flu 7 days back will be mentioned high likely in vestibular neuritis. Also, no wonder in vestibular neuritis there will be some kind of test like vestibular function test positive. Please write this thing, vestibular. Sometimes they also mention vestibular function test or caloric test. So these are the some type of test they might be giving you in the lab. All right. So this is something to remember. Now, Meniere's disease, often they will be testing you according to Rennie's and the Weber's as well. So if anyhow Rennie's and Weber's is mentioned, they might be talking about the Meniere's disease. Right? Okay, let's finish this. Guys, Dr. Nasmus, let's focus on this one. Let's focus on this one. Like you need to know like how to differentiate between these four important five actually. All right. Now, next thing, some of the cases like diabetes, hypertension, especially diabetes also associated with hypertension so often. So in those type of cases, it's mostly drug related, the vertigo thing happen. In those cases, mostly drug related vertigo thing happen. Okay, that's the thing. And BPPV, the surrounding is spinning. That thing to remember. The BPPV, your surrounding is spinning. And also one thing to remember, out of them, which one is so sudden? Like all of sudden, like, someone just came to home and just sleep and the surrounding started spinning. This is high likely BPPV. Okay, so positional. Even when they go for some travel, like if there is some shaking in the car, they start having again some problems. So those are the BPPV. Have you heard about two terms like Hall pipe maneuver and Epili maneuver. Hall pipe maneuver is used to aggravate the symptom. Epili maneuver is used to correct the symptom, isn't it? If you go to YouTube and search about these two terms, Hall pipe maneuver and Epili maneuver, there's some nice videos given. Okay. So now you understand, how to differentiate in exam in very quick session. Okay. With the simple word deafness, and also upper respiratory tract infection, and also surrounding spinning when they just sleep. The world suddenly starts shaking, and it starts so quick. Something which started so quick, again BPPV. So time duration also matters, but most cases in our question we get benefited with BPPV if they said sudden onset of headache. All right. Now you guys ask me the questions actually from the thing which you wanted to ask. Anything, guys? So positional, these are, I think this one will help. And don't forget to read about the Redness and Weber's. I hope so the concept is clear. Redness and Weber's, yes. All right, thank you for mentioning. A 54-year-old has a cardiac and was successfully resuscitated following defibrillation, was admitted to ICU. These are the findings, and following ABG is like this, as you can see. Most likely, important step. This one, is nothing to explain unless you guys answer quickly. Time is almost up. All right. And we request the candidates to use a laptop for better view. If someone is using mobile, you are not getting the full feature, definitely. So next day, always recommended to use the laptop. Now in this one, our answer is yes, increase ventilation. All right. So increase the ventilation. Some of the questions are so type as long as the previous one. All right. So there's a one question I'll explain a little bit more. Some post of oliguria. So in that one, catheter related some of the issues. That one I'll explain more. But these are, I think, simple type of questions. One of the question, if you see, when to start the ionotropes if cardiogenic shock, like post MI cases presented with hypotension and blah blah, this feature, cardiogenic, we start the ionotropes immediately. Right. Metabolic acidosis, we start immediately sodium bicarbonate. So like few things. And fluid challenge, I'll be talking shortly. Without any delay, past 3 years, 30-year man has been having penile pain when he urinates, and he otherwise fit and well. There are 4 tender ulcers in the penile gland. So genital area having ulcer, what do you think? Most likely diagnosis. Genital area which is having ulcer, which is painful. So high likely the answer is herpes. This is nothing but herpes. If I say chancroid, which one comes to your mind? So sometimes they might be also playing with you. So painless chancroid. What do you think? Syphilis. And in this one, another term to be considered is 4 number, so means multiple. Herpes usually has multiple things. Another type of ulcer that is usually single and painful. Name one of them. Ulcer and it's single and painful. Not the herpes one. Any other thing. Very well done. Haemophilus ducrei. So sometimes it is written like this: do cry. Why cry? It's due to pain. So Haemophilus, do cry. Next one. I think after 20 we'll go for the break. A 60-year-old man with metastatic bladder cancer, and he's on morphine. No wonder someone is having cancer, terminally ill patient. There is provision of using powerful analgesic because nothing you can do except for releasing his pain a little bit. Pain not still control, and dose is increased. That will break the dose. Had to increase the oral morphine to pain not control. So what you should do next? What you should do next? No, like there will be resistant and a lot of other thing can develop, right? So it's better you switch to some of the other variety because you are already going through quite a maximum. Okay, so you are already going through quite a maximum. No, like if morphine not working, still going with the all are opioids. I agreed on that one. Um, because you can see doses increased to like this amount. Already it's going through quite a maximum one. So see, there are a lot of side effects of morphine too. You should also consider that one. There is a word, it is said risk versus benefit ratio. If you increase the dose, rather than have your benefit, the chances of risk is more. So better we don't go in that way. You know that I think morphine has a lot of type of side effects. One of them is respiratory, depression thing can happen, especially when someone is in very higher dose. All right. So risk versus benefit ratio you need to consider. Already the person is going through maximum. Now, if you increase rather than getting the benefit, because the things is not controlled because of the typical morphine, it's not working. So we change into some other variety. All right. So it's oxycodone. All right. For this one, you can read. There are some chapters which is like palliative medicine. Okay, palliative medicine type of chapter is present in John. There's a one I know in John Murtagh. It's present. One of the nice book for MC, palliative care, and also some of the places in Davidson is also mentioned. Okay, the palliative care. It is little different, guys. Like the way we think in palliative care, it's not the same actually. We usually think the way the palliative care is little different. Okay, so before going to break, this is the last question. 25 years old female, metastatic breast cancer to the lung with dry cough. Already having metastatic breast cancer, which is not an uncommon thing. The cough is not responsive to some of the things given, responded minimally to codeine for 7 days. What is the appropriate management? Okay, terminally ill patient. So he's getting opioid already. So terminally ill patient, and the patient is getting some kind of opioid. Oral morphine, I don't think so. It's that much, I think, useful. So first of all, responded minimally to codeine, which is an opioid. Okay. So oral morphine switching a codeine to oral morphine, I'm not very agreed with the fate of the codeine. So better we switch to some of the local anesthetic thing that will work better. So that is the reason we choose the B here actually. But it is doubtful. I also have some doubt on the oral morphine. This one I like to review again. So if there is something new came up, I'll be telling. No, but if IV morphine, then it can be like IV subcutaneous. Yeah, but it's not mentioned. Yeah, I agreed with someone said subcutaneous morphine this thing, but it's not mentioned here. If you can see, if that one is present, then I could have think that one, but that is not mentioned here in the oral morphine. Yes, I agreed with that one. That one can be given. Yeah, that's trick actually. You see, oral given, but not subcutaneous or IV or the drip. Okay, one more question before going to this is a very small one. A 3-year-old drooping of saliva, temperature is this with stridor. What to give? Quickly speaking, the diagnosis is what? Temperature is high. Stridor, it's not mentioned what type of stridor. It's not mentioned what type of stridor. But drooling of saliva and stridor together and high temperature, I think that can be epiglottitis. Okay. So if it is epiglottitis, high likely we like to intubate and ventilate in presence of if you want to extend that word, in presence of anesthesiologist. There is a word that is told in case of epiglottitis. Do not examine the oral cavity. Do not examine the oral cavity. All right. And there's another interesting position they assume, it's called tripod position, if you know that. And about the stridor, usually E for expiratory stridor. I repeat, remember one thing, E for expiratory stridor. Okay. And in case of croup, inspiratory stridor. Maybe the recolor has failed to pick up that line. So sometimes they also mention, especially in case of croup, they often mention inspiratory stridor. Right? Let me show you something. Epiglottitis. Okay, this chart will help a lot of you. Sometimes they might come up with organism name like say epiglottitis, number of organism causing epiglottitis, Haemophilus, number of organism causing croup is parainfluenza, bronchiolitis, respiratory syncytial. We, I think, know that croup is between 6 months to 6 years. Bronchiolitis usually less than 1 year. Bronchiolitis, low grade fever, usually like 38 and something like that. Usual cases. Now, one thing that is contradicting me here is epiglottitis. I was expecting very high fever, but not always so high fever is evident. It depends on the also surrounding feature. So when you go to the main exam, then you will get to know that what is the actual finding. Also, you need to see the stridor. Is it an inspiratory stridor, expiratory stridor? You can see that one. Group, sometimes they mentioned about the Brazikov. Okay, some barking of Brazikov, usually they mention it. All right, and you see this one, they are assume a tripod position and their eyes will follow you. They will not move their head while you are going. They will follow you with their eyes because the some of the portion of the body is stuck. It's painful to move. And there is a word rare cherry epiglottis for epiglottitis. How to treat? Since it's caused by Haemophilus influenzae, so you need to start with an, I think, broad spectrum antibiotic. Okay. So croup is very important. Epiglottitis, bronchiolitis, all of them are so important. All right. What is the number of investigation for bronchiolitis? Anyone? Before I move on. tracheal tug is a keyword, right? A child less than 1 year with wheeze and tracheal tug and low-grade fever, so bronchiolitis. What is the number one investigation? Answer is anyone? Nasopharyngeal swab. Then comes the X-ray. Okay, this is an interesting point. Nasopharyngeal swab and do the PCR, then comes the X-ray. Usually we always answer the X-ray, but in this case it is little different. Yes, someone said is correct. Nasopharyngeal swab first, then X-ray. It is written that X-ray if doubtful cases. So that's the extra thing. All right. And in case of group, you should know the management: mild, moderate, severe. Okay, severe cases you can go for nebulized adrenaline. In case of group, in earlier cases you can go for the other treatment like conservative nebulizer and then also steroids. But in severe case of group, you definitely need nebulized adrenaline. All right. Yeah, see adrenaline. Okay, guys. So we are going for a break now. Going for a break. We'll come back and start. Some people wants to pray, including me. So break time. We'll come back. We'll go for some quick discussion. No, it will take a lot of time. Asthma. I think if you can just go to YouTube for asthma management. Asthma is a big chapter to discuss. We have classes for that one. I think. Oh yes. Maybe not today. Some other day I'll try to discuss asthma, because asthma it will at least cost me 15-20 minutes if I get into asthma management. All right, so I'm going for 10 minutes break. It will show 8 minutes, but I'll be going for it. All the best. Because some of the doctors are here to also solve maximum numbers actually. So I have to look after everyone. Like it's nice to, because we have already a big setup of classes. Like I think 2/3 of our doctors are already came through our regular classes. So they want me to be quick now actually. Okay, everyone. So we are back after the break of 10 minutes. So if there something you guys like to ask, feel free to ask question in the box or unmute and ask me directly. So it's totally fine asking anything. Is there anything, guys? Or I'll just move anything you write. I'll do that. Is there anything you guys want to ask? Okay. I think some are having longer breaks. Yeah, let's see. Like files will be given, so as much as possible we'll be covering in class. My class duration is 3 hours, so in 3 hours, as much as possible we'll be covering. I think it's not about the points. I can just quickly go with ABCD, but in that case, maybe you will not understand a lot of things. Yeah. All right. No worries. File will have more questions, definitely. So I'll give you the file. Okay. And about discussion, as much as possible, we'll discuss. No problem. 330-year within a 3 days history of painful urination with vesicle around the frenulum. I think someone's microphone is on. All right. Make sure it's muted. All right. Okay, now, a 30-year with 3 days history of painful urination with vesicle around the frenulum scrotum. What is the diagnostic investigation should be carried out? So painful urination. So if this is again a problem related to genital problem, genitalia, near to that there is vesicular eruption and painful urination. So what is your diagnosis, the thing that is coming to your mind? Anyone? What is the diagnosis that is coming to your mind? It's high likely. So vesicle or maybe multiple vesicle. It could be. So high likely herpes actually. Right? So diagnostic investigation they are asking. So more common, I think herpes is so common to be honest. So all you can go for is A, testing for herpes. I repeat, you should go for testing for herpes. This is the important thing. Next is the interesting one. I'll show you. This one is you need more actually. Learning is a super high yield one. And very likely many of you will get this question. 1 year boy with persistent diarrhea, abdominal pain, and short stature. Remember one thing, short stature doesn't always mean it's familial. It can be pathological due to nutrition, lack of nutrition and proper, elements which is required for growth. Now, IgA, TTG negative. Are you familiar with this kind of word? IgA, TTG negative. What is the investigation to do next? What is the next step of investigation, guys? Is it a duodenal biopsy? Is it a IgA, TTG? Now, the diagnosis, early age group, GIT problem, and this short is due to lack of growth, lack of nutrition, IgA, TTG negative. So this is high likely celiac disease, first of all. We know one thing, in celiac disease, the investigation of choices, initially we can go with some of the investigation like anti-endomysial antibody. Then next would be anti-transglutaminase. And confirmatory would be duodenal biopsy. I repeat, confirmatory duodenal biopsy or small bowel biopsy for celiac disease. Another differential diagnosis of celiac disease to remember, I repeat, another differential diagnosis for celiac disease to remember is minor thalassemia minor. Okay, please remember this one, thalassemia minor. All right. Now this one to see a little bit. What is ITTG, IgG? It means tissue transglutaminase. Part of evaluation of certain autoimmune condition, probably celiac. Celiac disease, antibody process, two types of antibody that attack the tissue transglutaminase IgA in this gene. Okay, so we have this one, right? All you need is this one too. So that's the so since this condition asked us next investigation, so this is obviously if they would have asked the same thing, if I just change it, how to confirm, or if I say most correct, most appropriate, so in that case it would have been duodenal biopsy. So in this one, IgG, TTG, this one is correct. So here is the thing which I took from Medscape as well. So preferred, as you see, IgA and TTG. Okay. So few of the informations are given here. So informations are given here in nice way. So our answer again, I'm showing GTTG. This is the answer. Okay, so read the celiac disease really well, guys. Read the celiac really well. In celiac disease, learn about the clinical feature. Often can be remain asymptomatic. Do understand. Learn about the investigation. Investigation is so important. Learn about initial. Learn about next. Learn about best. Okay. Also learn about the management. Management is gluten-free diet. Okay. Gluten-free diet. Remember, these are the food where gluten is present. It is called brown. Barley, rye, oat, wheat. I repeat, barley, rye, oat, wheat. These are the things which is having gluten. So gluten usually affects directly the intestinal villi. So that is the reason celiac disease has subtotal villous atrophy. Subtotal villous atrophy. And which you will get to know by doing duodenal biopsy. Okay. Moving forward. 36-year-old woman. Okay, I'm giving 1 second time to writing down few things. 36-year-old woman has been using OCP for 10 years. Which is not a good idea always, continuously using OCP. But anyways, who presented for bright red vaginal bleeding. She is in a stable relationship. Cervical smear reported normal. What is the most likely diagnosis? OCP taker. OCP taker for long time. So OCP taker for long time, there's high likely of development of, no doubt, this is a very clear cut question, cervical ectropion. OCP taker, cervical ectropion. Guys, here like to ask, do you have clear cut idea about menopausal bleeding, postmenopausal or perimenopausal bleeding? Do you have clear cut idea like when is endometrial carcinoma, when is DUB, when is atrophic vaginitis, when is cervical cancer? Yeah, because some doctors could be also in hurry. Is it necessary? I can, but I need more people to answer because some wants to be a little bit quick. They have the idea already. Okay, only 2 doctors. Okay, a lot of doctors, I think. Yeah, sometimes you let me know. Like, if you have doubts, please do let me know. Okay, so quickly let's recapitulate abnormal bleeding. Okay, take your pen paper. This is an important thing. A lot of things will be clear today. Let me. Abnormal bleeding, post-menopause. I give a headline, post-menopausal bleeding. So example, some question can come in this way. Example, you will be given a question like say 49 year. I repeat, you'll be given say 49 years, maybe just now she is having her menopause. So bleeding within 1 hour, 1 year of menopause. What is the definition of menopause? It has to be bleeding free for 1 year. Then we can call menopause. But if she started bleeding again within the 1 year, means 6 months there was no bleeding, suddenly there is some bleeding, and now what is the cause? Is it cancer? Is it atrophic vaginitis because lack of estrogen, or endometrial cancer? Because there is a word told, any type of postmenopausal bleeding is considered you know endometrial cancer until proven otherwise. So is it also going in that direction? Answer is no. It is due to you know Graphian follicle. See, all the ovaries, the follicles are not dead yet. Some remains active. So active follicle, like Graphian follicle, from that, so that is the answer. Active Graphian follicle. I repeat, active Graphian follicle, that is responsible for initial stage of menopause. But it is not like 55 years, of course, 49 or even 50 years. But it depending when is the menopause thing started. Now, another thing, what happened after menopause? Like estrogen is decreased, FSH that is increased, isn't it? So if estrogen is decreasing, what thing can consequence can happen? So dryness of the vagina, first of all, hot flush, okay, menopausal symptom. So hot flush is one of the feature. So example, if it is given like this, 53 years bleeding, postmenopausal, so she will be having hot flush, and they might be also mentioning about bleeding, I mean vaginal bleeding, or painful coitus. If they mentioned about this thing, that can be atrophic vaginitis. And why this is happening? This is because of dryness of the vagina. This is bleeding thing happening, and this dryness thing all is happening because of lack of estrogen. So they might be adding, these are the few points to consider. 53-year just after the menopause, postmenopausal syndrome, hot flush to remember. Sometimes also they also give dyspareunia. Bleeding is the common, everywhere bleeding would be common, but this is atrophic vaginitis. Now another one, 65-year postmenopausal lady, suddenly she started having bleeding. This is high likely endometrial cancer until proven otherwise. I repeat, this is endometrial cancer until proven otherwise. Another postmenopausal thing, 65-year and bleeding, and when you do the the cascos or any type of instrumental procedure, you find some growth is coming. So what do you think, what could be that one? So elderly, even elderly bleeding, so which we thought endometrial cancer, but when you examine, I found some growth. Now is this one endometrial carcinoma, or is this cervical carcinoma? According to age group, cervical cancer can be any time, okay, any decade there could be cervical cancer. But one of the characteristics feature, from the cervix you will find some growth in case of cervical cancer. Also we find spatial history. Now you guys have to tell, for cervical cancer, what are the some types, what are or the risk factor I'm looking forward? Come on guys, anything to add in our box? Human papilloma virus, risky strain, if ever positive. Multiple sexual partner, okay. So these are the some extra points. Also smoking, all the thing, alcohol, all those things would be increased here. So multiple sexual partner, and if ever HPV, those are the risky variant. You can just type it in Google, or you can just check what are the high risk human papilloma viruses ever get positive. In that case, high chances of cervical cancer. And also family history, all these things matters. All right, so just remember these things. All right, so this particular thing clear guys, you can also take a picture of this one. I hope so this one was helpful. Like now we will be answering, because amenorrhea we got a question always, bleeding related we always got a question, so you definitely need to answer well this kind of thing. So these are the postmenopausal bleeding. Is it clear guys? So almost 4 conditions with bleeding I just explained. So these are the menopausal one. Now there's another one, menstruating woman who is having bleeding. I'm not over yet. Menstruating woman who is having bleeding. Now, menstruating women, sometime one key word we need to see in the exam. What is that key word? Like many of the female sometimes complains they started bleeding in between the mens, and if this is happening regularly, I repeat, so the term I'm looking forward, intermenstrual bleeding. So in a, say example, 30-year female, she's complaining of regularly intermenstrual bleeding for a few months. What is your diagnosis? Now your diagnosis would be cervical carcinoma. Cervical carcinoma until proven otherwise. Intermenstrual cervical carcinoma. Now, dysmenorrhea, I think there's no such female like, maybe never suffered dysmenorrhea. It's so common actually. Okay, so dysmenorrhea even looks an easy question. They will ask you, what is the first line management you need to do? So dysmenorrhea, first line it has to be NSAID or mefenamic acid, especially mefenamic acid. So dysmenorrhea, mefenamic, dysmenorrhea, mefenamic. All right. Now, a lot of people often confuse this one, heavy menstrual bleeding. So don't confuse between these two. What is dysmenorrhea and what is heavy menstrual bleeding? I hope so this is clear. Dysmenorrhea, that's the painful mens. I repeat, dysmenorrhea, that means the painful mens. Heavy menstrual bleeding, that's like heavy flow is going on. Now, what is the management of heavy menstrual bleeding? So in heavy menstrual bleeding, no, still we would say mefenamic acid. I repeat, still we would say mefenamic acid. Now, if the bleeding is uncontrollable or too much, then the answer is tranexamic acid. Will you agree? When the bleeding is uncontrollable or too much bleeding, or maybe vital is deteriorating, patient's condition is getting bad, now we go for the tranexamic acid. Okay, tranexamic you can understand. A lot of blood bleeding goes on. We give tranexamic, patient become okay. So there's a one word to consider: acute flooding. Flood you understand, like a lot of areas. Few time back there was flooding in South India. We saw tranexamic acid. We just now today solve a question. Young girl OCP taker and there was bleeding. This one we just solved a little while ago, and it was cervical ectropion. Cervical ectropion, isn't it? Another one to be considered. Sorry, so many things, but I just collected all of them. That's the thing. All right. So post-coital bleeding, I repeat, post-coital, there's another type of term, post-coital. So 55-year having post-coital, what could be the DD? Cervical cancer or atrophic vaginitis. But cervical cancer will have some growth at the same time. Atrophic vaginitis won't have any growth. Okay. Post-coital bleeding, so early and late age group. Late means the postmenopausal. It can be cervical cancer. It can be atrophic vaginitis. How to understand? Cervical cancer growth or human papillomavirus, multiple sexual partner history. These will be the points. Early age group postcoital bleeding. Consider simple thing. Don't think about the cancer first. Okay. So the common thing to consider it coming is polyp. So common thing, it is polyp. Another thing to consider, ectropion or cervicitis in case of OCP taker. So these are the common thing to consider. Now, if there is family history of cancer and this thing, in that case, postcoital bleeding can be also sign of cervical cancers. And now the bad one. So these are the not good one, but considering cervical cancer may be good one. So postcoital bleeding in early age group, good ones are polyp, ectropion, bad one is cervical cancer. All right. And the last point, last but not the least, DUB, dysfunctional uterine bleeding, which is so common, often the cause is not found, but it is believed that fibroid, which is the main reason. Okay. So in that case, so dysfunctional uterine bleeding to remember. Now, one extra thing to remember, fibroid plus pregnancy. I repeat, fibroid plus pregnancy. There is a special term sometimes used. Special term, fibroid. What is that one? It is called degeneration. It is called red degeneration. Okay, red degeneration. So fibroid is present and patient is pregnant. So red degeneration. So these are the points. I hope so it was helpful. I still took 5-7 minutes, but that might help you in the exam hall. If any question comes next time regarding this, I'm sure you will be able to crack it. I hope so you're confident now about the two things, amenorrhea, and one of the thing is the bleeding. So they can't stop you in gynae and obs. I hope so. All the best. Now next one, without delaying time, now 2-3 questions. I'll be going little quick, but sometimes some of the questions are so conceptual, you should know it. Like example, like chest pain. Sometimes also important question comes, and you need to know how to crack all type of chest pain. 72-year-old woman who developed sudden chest pain and has had surgery 6 days ago. Now, so because of I think the person was having surgery, lying down and having chest pain. Troponin was done thinking as MI, which comes as normal. What is the diagnosis? So the diagnosis, high likely. A is a terrible answer, probably. See, post-op surgical day 6. Guys, sometimes you need to understand what concept is going on. Post-surgical case, day 6. Do you think it is possible pneumonia? Someone who said pneumonia, do you think it's ever possible? Okay, it's not. It should be the first day. If it's pneumonia, fever, and all these things, chest pain, that should be the first day. That could be atelectasis or pneumonia. This is day 6, and the person is sitting for a while. So this is no doubt. This is pulmonary embolism. Someone said is for sure. Yes, that's the thing. This pulmonary embolism, because surgery patient is bedridden patient. This is a big risk factor. Like example, air travel from USA to India, say, total 24-hour flight. It is possible. Yes, it is possible. Right? Very, very important. Now, one thing before I left for pulmonary embolism, you need to understand the clinical feature like chest pain and this type of feature. You need to understand few risk factor to commonly asked recent surgery and air travel. Pregnancy can be also a risk factor. Now, pulmonary embolism, what is the initial investigation? Who can tell me that one? Pulmonary embolism, initial investigation. Then who can tell me what is the next? What is the best? This is a 5-star topic, always comes in exam. And while all I can see in last November, so all the important thing came. Even when I saw the another month, I saw also similar. So in the first 1-2 classes, like things would be new. Maybe later classes, thing would be much more easier for you. A lot of question would be repeated. Okay. Fat embolism can happen after breakdown of femur. Very simple. After breakdown of femur, the fat is released and it will be immediate effect. Very simple. Okay. Now thing is initial. I asked 2 things. Initial would be X-ray showing weight shape opacity, or they might give you X-ray as well in the exam. You have to understand. Next would be VQ scan or D-dimer, and best would be CTPA. So please take note. Initial X-ray, some cases CT scan too. Sorry, ECG too. ECG has a special finding. right? VQ, D-dimer, CTPA, isn't it? Okay, now let me twist. I always like things twisted. Okay, I'll give you two scenario: pulmonary embolism plus kidney problem. Okay, initial X-ray is done, and they are asking next. What will be your answer? Please tell. VQ scan or D-dimer? VQ scan or D-dimer? Which one? Repeat the question. Pulmonary embolism, all features present, and the person is also having kidney problem. What So in this case, answer is VQ. VQ scan. Now one thing is coming. Should we do CTPA in this type of cases? I repeat, should we do CTPA in this type of cases? Answer is no. The reason is it is nephrotoxics, because in CTPA dye is used, and this type of dyes, radio contrast dye, is nephrotoxic. Usually we should not do. There is a word that is told with caution you can do, but still those are hypothetical thing, right? Another thing, let's just consider the pulmonary embolism plus pregnancy. Right, let's draw a pregnant lady. Okay. Now, why I draw in that way? No offense, please. It's because the D dimer. It's because I just tried to draw D dimer. So initially X-ray, same question. Initially X-ray is done. Now I mean initially X-ray is done. And what to do next? That's how it was asked. Now you can do. There's a lot of evidences you can do actually. D dimer too. Alright, a bit hypothetical question, but you can do. And the next thing is definitely best is CTPA, no doubt. So this is the thing to remember for pulmonary embolism 5-star topic. And as we said, always there you will find some of the things controversial, as if like D dimer should we use in pregnancy, not should we use in pregnancy. Some evidence I found should not use some, but a lot of evidence we also found we can use actually. All right. So next one is another question. We should not take that much time. You'll be given a picture like this, and it's a bodybuilder, left flank, and pain for 4 hours. He's known to be diabetic and has been a drug complaint. And temperature is this, normal based on the image. What is the likely cause of this? So anyone who wants to attend this question? So do you think, everyone? Yeah, previous slide, it was next investigation. You were right. Yes. So this one is a blunt force trauma. Let's not, I think, make it complicated. It's an easy slide actually. It's an easy slide. You guys do this one. I'm just taking a 1-minute break. Okay, guys, I'm back. Sorry, I had to take a call. All right. So I think it's not a very tough question because it started with productive cough and yellowish green. Something with stake of blood means hemoptysis. Smoking history is there. Coarse crepitation, bronchial thickening, exosus patchy, opacification, percussion note, lower zone of the right lung, presence of weight loss, like dull in the lower zone. So what is the likely diagnosis? So anyone? Guys, you should mark this word. So many of you answered this one because of weight loss, I guess. Okay, lot of DD to think. Is that a feature of cancer? Okay, smoking. Okay, smoking also for cancer. Can be for a lot of other diseases. Is it for cancer? What do you think? Do we find cancer like patchy opacification or a nodule in the lung? Please and correct me if I'm wrong. Do we find cancer as like a node or a small coin-shaped lesion or a mass, or we find as a opacification? So small nodes or small mass, 2 centimeter mass, something like that, but not as a patchy opacification, isn't it? And also that word, bronchial thickening. Some of you are also thinking maybe stake of blood. Is hemoptysis is only present in cancer, or there are more other causes of hemoptysis? There's more other causes of hemoptysis. They also said initially it was green. That might be indicating something. So in this case, what we really need to do is go for this one, bronchiectasis. It's C. Tricky, right? Very, very tricky. So productive cough, green because pseudo can be. Hemoptysis, also a feature of bronchiectasis. Smoking, also related to bronchial thickening, much related to bronchiectasis. And this patchy opacification, weight loss, definitely. And percussion note also could be down, quite a possible. Interesting question, right? Should not have made mistakes. So this type of question, answering in proper way, could be a parameter. Yes. But bronchial thickening, when I said bronchial thickening, you should definitely start thinking of bronchiectasis. Two words, like sometimes I said one thing, compare and contrast in my regular classes. Because a lot of thing I start doing that one, compare and contrast. Like bronchial thickening, this bronchial thickening is going with bronchiectasis. Pleural thickening, if I say another popular, right? This is a popular one. Pleural thickening is related to fill in the gaps. Maybe a construction worker, okay, who is having pleural thickening. This is mesothelioma. The one who said is very well done. It is mesothelioma. Well done. Pleural thickening, mesothelioma. Okay, and also like construction worker or it's an occupational lung disease can be presented with pleural effusion also. If it is pleural thickening, mesothelioma, what is initial? What is next? What is this? This is the exam question, guys. If it is mesothelioma, please tell me. Initial, next best. Initially X-ray, then CAT scan. CAT scan means it's also CT scan. Best is biopsy. Please remember. Very, very important, guys. Yeah, bronchiectasis. You can see the clear difference in thickening. Next one, without any delay, I'm giving you guys 15 seconds to answer this is not really something very concept thing I can bring. Rather than you can answer that one quickly. It's something related to emergency department with accused wheeze attack with chest involvement of like this. Most significant feature showing impending respiratory failure. Your time starts now. Most bad, I think, is losing the consciousness. I think all of you are correct. So no confusion, no need to discuss this question too much. Okay, so sign of marked respiratory distress. These are the things, and this can be a parameter of drowsiness as well. I mean the respiratory failure. Next one, X-ray showing curl. See, this question came up. Whatever I was telling, X-ray the picture showing curless B line signifying pulmonary edema, IV furosemide oxygen. So general thing ABC oxygen given, IV furosemide, breathing improved after administration of furosemide. Keyword. When said curless B line, it's a heart failure case. What to what which drug to add here? The is first thing to consider whether my patient is stable or not stable. So we choose ACE inhibitor because this is a stable patient. I repeat, we choose ACE inhibitor because this is a stable patient. Initially, patient was in trouble. Why? Because he is having acute symptom of breathing problem, cough, and all this thing. So we give furosemide, and after stabilization, we give ACE inhibitor, lisinopril. So this will help you guys in the choosing the treatment of heart failure. So acute and unstable. You see this one, acute and unstable. This is diuretics. Stable and also acute. Okay, still acute, right? Like you just settle down the patient properly. Okay. No, not really can't. We can actually like see few of the things a little different what we actually use in day-to-day life, but not at the same. Like if patient presented with acute symptom, like say example, present to the emergency department, patient is having acute cough, breathlessness, serious symptom, we usually cover them with diuretics. Then we observe the patient. Maybe after 1 hour, 2 hours, the patient is settled a little bit. Then you can start the ACE inhibitor. All right, that's all. Now, example, if I ask a question, can I use beta blocker here? Just adding something. Sorry. Can I use beta blocker here? Unstable and acute. Answer is, can I use beta blocker here? It's okay, participate. Answer is no, absolutely contraindicated. It is absolutely contraindicated. When the patient is stable, then we can use the beta blocker. Why we don't use now anyone? Now this is out of the PLAB that uh, beta blocker, about beta blocker. Why not beta blocker? It's because contractility. Remember one thing. Three things I'm going to tell you. Please remember for your lifetime. Um, heart failure is related to decreased contractility, increase preload, increase afterload. Now, what are preload, afterload? Please check if you have forgotten. And decrease contractility. So when we module drug, we have to increase the contractility, decrease preload, and decrease afterload. This is your plan for the drugs. So you should not give any type of drug. that will decrease the contractility. So beta blocker is one of those type of drug. It is not because of the spasm, guys. Wrong concept. Not because of the spasm. Okay, it's because of the contractility of the heart. That is also there, bronchospasm. That's secondary here. Okay. Now here, why in previous question, I think some people need to clear the concept. Why people has the breathing problem in heart failure? Is it bronchoconstriction? Is this the asthma? That's why the person is having uh, breathlessness. Is it because of the bronchoconstriction, or is it because of the pulmonary edema? You have to clear that out. Is it because of pulmonary edema, the breathlessness problem? It's because of the pulmonary edema, not the bronchoconstriction. Bronchoconstriction goes with the asthma thing. Fluid overload, someone said yes, more correct. All right. Without delay, let's do quick 5 questions. Women who started chemotherapy started for Burkitt's lymphoma. Urinary output reduced to 40 ml in last 24 hours. Lab test on admission were normal. Rab levels now raised to potassium. Raised urea, raised creatinine. What test would point to the cause of her deterioration? Without any delay, this is something happened due to chemotherapy related problem. Let me mark the things for you. So after chemotherapy, why kidney? Like, what is the question? Understanding question is also part of exam. Like, why kidney is having issues after chemotherapy? Very simple. Someone said is very correct. Is tumor lysis. That means the gout, that thing, and gout thing crystals that can also involve the kidney. So this is no doubt. This is the urate. So chemotherapy induced, not I should say gout. Chemotherapy induced, hyperuricemia. Also remember one thing, this hyperuricemia can happen in some other cases, like what? Any drug induced hyperuricemia. Name a drug that can cause hyperuricemia, popular question. And that is diuretics, especially thiazide diuretics, to remember. And one of this one is chemotherapy induced, to remember. Well done. Man who had surgery few hours ago, urine bag is not draining. Keyword is urine bag not draining. Vitally, the person is stable. What to do next? Vitally stable. What to do next? So this one is, you should definitely, those of you who are working, even if you have done internship, definitely you should know this is check the catheter. So check the catheter. So we have a similar question like this one. Sometimes the confusion thing arises with this type of question. Like, even after a hemicolectomy surgery, post-operatively 100 ml given private fluid. Now the patient is having generalized abdominal pain. Patient is catheterized. If the patient is already catheterized, then what you should do next? So now this is another next level question. If already catheterized, then what you should do next? Near us, going for renal ultrasound. Are you sure, guys? Let's reveal the answer. There's a post-operative oliguria. That's the theme. You will high likely you'll get a question from there. Answer is C here, and I'll tell you why. Now, formula for cracking this type of question: if with catheter, choose renal function test or the electrolyte. Without catheter, you can definitely choose the catheter, which is also called catheter flush, or the IV fluid type of thing. Okay, so please remember this formula for cracking post-op oliguria case. So please write it down in proper way. To cracking post-op oliguria type of cases with catheter, without catheter, please follow these formulas. This will be also helpful for your upcoming life. That is after that. Someone said ultrasound, that is after that. You think normal, sensible way. Don't you use the, regular routine test first, isn't it? So you should definitely check those things. Then you go for the some other ultrasound of thing. Ultrasound later. Like it's not like we won't do, we'll do, but little later actually. And this is not, the area for first ultrasound. The ultrasound, the typical one, it will take some time. All right. Okay. So this one is a very, very clever one, guys. Please remember, very tricky question. And often people get it wrong. No, emergency lab thing is not Bangladesh, so those emergency you won't take that much time. Okay, in those country, the blood and things won't take that much time. Okay, the blood thing comes quickly. In our country, we have to, wait. When we are talking about a serious patient who is in post-op, definitely the patient would be in ICU and this type of thing. Yes, so I think that's the main thing. Yes. It's simple. With catheter, without catheter. Okay, use the formula. To cover a lot of things, remember the formula. All right. Yeah, if it's regular classes, we can, even for renal, we have 3-hour classes. So many discussion we can do, but it's this squeezed class, so we need to cover more concepts. So if you remember this formula, at least learn how to crack down the question. All right. If I get time, I'll give the explanation in the group later. Actually, yeah. 57. A few things also comes with your own practice. If you already have practiced well, you will understand. Otherwise, you can also ask a senior, like why when catheter we are using, you might need to enlighten a little bit more knowledge about your own catheter use. Okay, so then you will get a clear idea. Or maybe you can ask a senior about the catheter using things. Okay, they will clear the doubts. All right, 57-year man presents with the lethargy and he looks pale. Blood pressure is this, urinalysis is this. I can see some protein, like whenever you say 3 plus, what is it called? Massive proteinuria. Creatinine also elevated, other tests are normal. What is the investigation of choice? What do you think? This is a diagnosis going with multiple myeloma. Where is my yes? This one goes with multiple myeloma, as you guys can see. First of all, I cracked this question when I saw massive proteinuria. Then I found the kidney that is involved, which is also part of multiple myeloma. Okay, so you see this one, SMA keywords, old age, pale means anemic, and kidney involved and urine protein. This is enough information to make a diagnosis. Now, if I ask you a little tough question, maybe some of you already know what type of anemia is present in multiple myeloma, because sometimes they also give lab and you will be little confused. So what type of anemia is present in multiple myeloma? Normocytic normochromic, microcytic hypochromic, macrocytic. So well done. It's a normocytic normochromic. Correct answer. Now, some people said, Doctor, I think there is blood pressure high. How do you explain? Remember one thing. So multiple myeloma is a cancer patient, no doubt, right? So cancer patient can develop hypertension due to any toxic therapy. This is common in any types of cancer patients, right? We don't know the patient is getting chemo or not, or maybe in initial stages. But in cancer patients, getting hypertension after toxic therapy, chemotherapy, is not uncommon. So what we need to do here, furthermore, urine for Ben Jones protein. All right. So I have an old note, book hand note, just to see the labs, guys. Just want to show you how the labs are looking like. We'll get these slides, so don't worry at all. Okay, I'll take your emails and we'll be sending the notes. When is you guys are having the exam? Everyone is same date, right? March, right? Everyone? Okay. Can you mention your date? I mean, everyone, can you mention your date? I think one group is the March 12th, one group is March 12th, and another is the 25th. Yes. Okay, well done. Now you guys will crack it. All my best wishes with you. So now let's see the lab. I have shown you guys already, the labs are coming and increasing because their treatment protocol even in UK is, nowadays a lot related to the labs actually. Okay, so even in case of multiple myeloma, I'm coming to that one. There's a very nice mnemonic I'm going to show you. So hemoglobin decreased. That's why pale. WBC decreased. Platelet decrease. Yes, sir. On the other hand, increase. This is the most important thing. Why we call it multiple? It is a disorder of the plasma cell, and that's why we think this is a cancer. Okay. Serum protein decreased, but urine protein increased. That's why. Calcium also increased. Protein electrophoresis increased. Benjone's protein, of course, and bone extra. So these are some of the nice lab-wise feature. Some lab-wise feature. Very popular, one of the mnemonic I use so often. It's a old crab. Just imagine this crab. Who likes crab here? How many of you like crab? Okay. Well, it's just little, break the ice. Everyone could be little storming their brain. Okay, some people fried. Yeah, Shubro, I know well. You were in Maldives for a while. I think a lot of crab, even if you are not a crab user, you will be in that case. Okay, fish and crab, I think the best friends there. Okay. Here we, look for seafood so often. Anyways, the old crab, multiple myeloma, often presents with back pain. Remember one thing, elderly age group, presents with back pain, often it can be multiple myeloma. Another thing, old age, um, that back pain, except for mechanical trauma or something, um, what other thing else it could be? Tell me a very important DD of multiple myeloma. The patient presented with back pain. Again, multiple myeloma. Patient presented with back pain. Say not elderly, it can be also little early age group, say middle age group. So middle age group and back pain. Now what do you think what it could be? No trauma. Anyone? Very well done. Prostate cancer can be. Yes, prostate cancer with bone metastasis. Actually, to get the full mark, prostate cancer with bone metastasis can be also presented in that way. Now, one thing to consider, how can we differentiate then? Is it a prostate cancer induced problem or the other thing related problem? Now, age is not the parameter. Prostate cancer can happen at any age group, middle age to elderly. Calcium elevated, as you can see in multiple myeloma, renal failure thing, anemia, bone light eclesion. This is one of the thing, bone light eclesion. Okay, so differentiating point, multiple myeloma versus the cancer, prostate cancer, is this calcium thing. Okay, please mark it down. How can I differentiate? In the main exams, I can differentiate with the help of the calcium. So calcium on elevated in multiple myeloma, it is usually very common. Calcium remains okay in case of the prostate cancer with bony metastasis. Right? So old crab, it's a nice mnemonic to remember. This one I just brought to explain the treatment. Initial therapy, combination of the names which you can write. Please take a note. Initial therapy, combination of this drug. Use of melphalan in elderly fragile patient who can tolerate adverse effect. So sometimes these things we have seen in the question using. Right? So please do remember this. Okay. Sorry if I'm a little quick, but you will get these slides so when you can utilize them. Anatomical structure pierced by trocar. This is a weird question. Okay, so not that much time I'll give you. And cholecystectomy at the midpoint between the midline and mid axillary line. What is the answer? Just tell quickly. This is not a conceptual question. I need a quick answer. This is nothing to explain. It's all anatomical thing. So those have solved it. They know it. So this is E. So just remember it or check the anatomy. I also don't remember that much anatomy. So just go and check that for the answer. Let's not waste time. Nothing conceptual here, especially in anatomy. If brachial plexus, I could have explained something. And here, nothing to do actually. You just remember it. Let's not waste time. I can give some more time in other one. Middle-aged guy, 2 episode of microalbuminuria. So urine, right? Blood pressure is 128/70, normal renal function. He was overnight, BMI was given, is high. What additional therapy would benefit this patient? See, it's not a tough question. It's something related to antihypertensive. So, someone presented with proteinuria. What is your choice? Someone presented with microalbumin. What is the choice? I think same drug. It's a very easy question. Everyone should know it. This is without any delay. So, microalbuminemia or proteinuria and BP high AC inhibitor is the choice according to Davidson's medicine. I'm showing you a chart. Guys, are you guys clear with the antihypertensive and special situation? Antihypertensive asthma, antihypertensive pregnancy, antihypertensive uh, vesicular reflux. Everyone know that one? All right, I hope so. At least I give you a chart. Those are, I think, little shy telling that. Okay, maybe you can take a snap for this one, guys. It will be useful for you. Antihypertensive and different other situation, which one is choice? And different situations are given here. One question is so high likely from antihypertensive type. Looks like most of you might be aware of this type of thing. All right. Next one. When you see the stem, you will be understanding this is something a question is coming regarding leukemia or lymphoma, and you just need to pick up the answer. Okay. So always I'll check here, here, and here. I get an idea very quickly. Okay. So woman with her, I think neck lump which is painless, not mobile. She has swelling in her cervical nodes and supraclavicular node, axillary nodes, and inguinal nodes, all bilaterally. And these are the things. Other investigations were mostly normal. Blood film level, lymphocyte with smear cell. Your exam is later, Dr. Asim. You can go, I think it's okay. You'll be finishing. Yeah, like 10-15 minutes more. I think till 50 we'll do a little quick. Okay, so this one we are going more with, yeah, CLL. First of all, it's with the age group you can differentiate a lot of things. Like ALL, it can't be in elderly, like usually, right? So it's high likely CLL. So CLL, if you see a lymphatic cell. So what type of cell was present here? So lymphatic cell. Already, if you say the lymphatic cell is given. The lymphatic cell. Also, the age group, if you see, is elderly. So CLL, elderly. So this is another that. Burkitt's early age group here. Why not Burkitt's? Because Burkitt's early age group, and the child who is having some, massive neck mass. So that goes with the Burkitt's. Burkitt's, the age is differentiating point here. So different types of leukemias. So age is a very important parameter. You can differentiate a lot of things so easily. So just with the age, I make a quick diagnosis, even though the lymphocyte thing was mentioned. But just with the help of the age, I can quickly able to make a diagnosis. So same thing I want you to do. Okay, 19-year-old male, painful swollen of the testis of 4 hours, had intermittent pain in the same testicle. Over last few months, he is sexually active. What is the most appropriate management? So something related to, I think, testicular torsion. If torsion, and yeah, it can be common in sexually active people. So this is high likely without intent. So 4 hours, it's within time. Up to 6 hours, you have time. So in this case, okay, we can, so this is torsion. So without any delay, refer to surgeon, he will do the surgery. So don't forget to learn about few things, especially torsion versus epididymoorchitis. Torsion versus epididymoorchitis. I'll ask you a quick question. Gentle elevation of testes worsening the pain. Is it torsion or is it epididymoorchitis? Gentle elevation causing pain, that is torsion. And gentle elevation, releasing pain, epididymoorchitis. Urine tract infection type of feature. Urine infection type of feature present in epididymoorchitis. Okay, so these are the few important points to be remembered. Also, don't forget testicular mass. Patient presented with painless lump in his or his testis. What is the next thing you should do? This is an important PLAB question. What is the next thing you should do? Patient presented with painless testicular mass. What is the next thing you should do? Okay, options: ultrasound, um, beta HCG, alpha fetoprotein, biopsy. So the answer is, initially we go for ultrasound. Then we go for which one? Beta HCG or alpha fetoprotein? Then we go for beta HCG. Then we go for alpha fetoprotein. Then we go for biopsy. Am I right? Everyone agreed with me? We go for also biopsy at the end to confirm, right? Everyone agreed? Okay. Thing I said, ultrasound for testicular mass. Ultrasound, beta HCG, then alpha feto. Then I said lastly, biopsy. Okay. No, no. You guys agreed with me, but I'm not agreed with myself. Taking biopsy from a testis is absolute contraindication. How many of you know that? Or now I said you remember. So they'll be tempting you with this kind of question. Taking biopsy from testis is absolutely contraindicated. Okay. Yeah, no worries. I mean the procedure, I think way of taking the biopsy, like the biopsy transscrotal, there is a one route, and transinguinal. So transscrotal, piercing the scrotum and taking the biopsy, that is contraindicated. Even if you do the surgery, transscrotal surgery, contraindicated. So the which way to perform the surgery? Transinguinal. Even if you go for biopsy, you have to go through the inguinal area. Okay. So transinguinal surgery, transinguinal biopsy, not the scrotal. Yes, nicely said. A lot of anesthesia you can give, but it's because of the seeding. It's because, like, if there's the testicular thing, if you go with that procedure, transscrotal, there's chances of seeding. Okay. Quick question, guys. It's something. The boy is short. Some features given. How to evaluate his short stature? I think we all know this one answer in our life. Some even not giving timer. This is without any delay. Check the X-ray of the bone. I think we all are familiar, and I hope so all of you are familiar with growth chart. So one growth chart might come. So short stature or pathology, so one growth chart might be tested at the same time. If something came up, we can also discuss next day about growth chart if someone does not know how to interpret a growth chart. I have so everyone familiar with growth chart interpretation. You can also check the Kaplan if you want. There's a lot of nice charts are given in Kaplan pediatrics. So basically I'm doing this one. Next one. Okay. 79 years old, quite old, I guess, presents with the increased thirst and polyuria and constipation for 2 weeks. There's increased confusion over last 3 days. He had left mastectomy for so this is taking this drug, temperature, no papilloedema or focal neurological sign, urination, trace kitten, most likely cause. All right. Polyuria, constipation. I got my points. Polyuria, constipation. And increased thirst is a hypercalcemia feature. Right? Now, if it would have been a DKA, there would be focal and some deficit things would be there, like deteriorate level of consciousness. But that was there. Increasing confusion over last 3 days, that was there. But nothing mentioned that person is having, diabetes mellitus. First of all, it can be. It's another thing. It can be. Say like trace amount. Right. All I feel less info to establish decay. Okay, so You see how the patient presented with. This is not the way patient of DKA presented, if you have seen. This is not the way patient presented in DKA. Your patient is already in serious trouble. Okay. So I don't think so. It's the DKA actually. So some of the, it can be DD, but not the answer here, I guess. So I go with the hypercalcemia because thirst, polyuria, constipation, even confusion. Hyperparathyroidism, those has a lot of personality change and behavior related things that can be there actually. So you can match that one too. So I'll go with the hypercalcemia. But it's a controversial one. Yeah, breast cancer can be a hint in that way, like possibility is there in breast cancer. Yeah, true. Oh, this one is a direct answer, I think. Okay. It's okay, but you guys know the deal now. Elderly women having a hip surgery. So see, two questions came from pulmonary embolism. Two questions came from pulmonary embolism. Had a hip surgery on low molecular, still developed shortness of breath, chest pain. All right. So treat the pulmonary embolism, low molecular heparin, arrange CTPA. That is the thing. All right. So investigation already talked about. The drawing thing is done already. Next one, renal cancer patient who has morphine, good pain control, started vomiting, has placed on metoclopramide, after which he developed neck stiffness and rigidity. So possible, and I think very interesting question. I still remember, I think Shubro is also from Northeast, so he knows, I think, we know sir. So one time there was a patient and I was with my CA. So thing happened, a patient came and he was a little bit, bended or kind of like opisthotonus. So, that time we were young, enthusiastic, and we start thinking that, okay, maybe we found a case of tetanus. We asked few things, but the common patients. In that case, uh, often it happened that patient might not give sometimes history. You need to give emphasis on that. So we take the general history, but how he was looking like, so we think, okay, this is a for sure a case of tetanus or something like that. So me and CA, he came to the professor and he was saying he was smart enough, the CA, that he said like, there's a patient, I think, sir, you should look one time. And I said accidentally, sir, I think it's a tetanus. And he just looked at me, he said, oh, tetanus. And I thought, okay, I'm gone now. So that was back in 2000, I think, 11. So he came and he just asked one question. Do you had any vomiting and you took drug or something like that? And he just nodded the head actually. And the patient party from side, he said that pharmacist give us a drug. Okay. And it came out, one of the popular drugs, Stimetil or this metoclopramide, turned out to be the cause of this dystonia or EPS. All right. That was the scenario. Yeah. So side effect of metoclopramide, simple. Okay. So there could be a lot certain things like a lot of A, like acute dystonia, akathisia. Okay. It's acute tardive dyskinesia. So days, weeks, I think, months. That's how we remember. So very shortly, within days, it develops this acute dystonia. Hours to days. So this is a nice one to remember. Some of the A. Related to, it's called extrapyramidal symptom, EPS. Sorry for taking time, and I think 8 more. 30-year-old having progressive painless peripheral vision loss of 6 months of duration, nursing at night. A similar history in father. What to do next? Okay, 15 seconds to answer. Painless peripheral vision loss, 6 months of duration. Okay, so in this one, refer to, optician actually is not the proper word. Optometrist, there is another word. Like they can actually check the power and sometimes can refer to ophthalmologist. But that goes with in case of power, checking the power. But here's situation is more advanced, like progressive painless peripheral vision loss. So definitely without any delay, routine, I think you should refer to the ophthalmologist. So whatever those questions are related to refer often becomes the correct answer. So in case of question number 42, I think the correct answer is this one. Routine ophthalmology referral. All right. Now 43, let's finish quickly. Patient with 6 months productive cough and fever present and left-sided chest pain and nodes on breathing, absent breath sound on the left floor side and dullness on the percussion on the left floor side. What will be seen on the chest X-ray? Okay, keywords I'm trying to highlight: cough and fever. Absent breath sound on the left side. Also, dull note on the lower side. So all the things are in the left side. Absent even breath sound. Can it be pneumothorax? First question, even if it is present as a E option. Can it be pneumothorax? Answer is no. Because what is the percussion note of pneumothorax? Hyper dissonant. Okay. Now, does this patient has any kind of road traffic accident? Like see, percussion note dull, it can be hemothorax with breath sound absent on the left side. So can it be hemothorax as well? What do you think? Answer, it can be, but if it is hemothorax, in that case, there has to be some road traffic accident. It's not like productive cough and fever for few time. So dullness on percussion can be present. If you see this one, this pleural effusion is one of them. Pleural effusion. In consolidation, there's a word stony dull, but not always is used. It's dull also mentioned. Next thing that is coming, the breath sound. Is it the breath sound absent in this type of cases? Okay. Fever thing, it depends. It depends on what is the temperature, which is missing from the question. Fever is of two type. One, it is high fever. One, it is a bit low. So even collapse can be an option. Lung collapse, if you see and consider that one. Yes, question has also some problem. Okay, let's go by exclusion method. Hilar nodes that's related to sarcoidosis, that is out. Left lobe consolidation, like stony dull, often is the finding is stony dull. And yes, fever, and also one thing to consider, chest pain. So chest pain is also to consider. So chest pain, fever, maybe one thing with consolidation. Dullness also with consolidation. Now, the recaller said absent breath sound. Like, is it absent or diminish in case of consolidation? Usually diminish. So this is the one area which does not match with consolidation, only one area. But there's another thing, worst on breathing means a pain, something affected with inspiration probably. So that could be another keyword. Okay, so that one probably going, yeah, more with the consolidation. So only one thing that is not matching. It could be the recaller's fault. We don't know yet. So absent, it could be diminished breath sound, I think. Okay. Yeah, but that kind of silent chest hypothetical question, usually they tried not to give in the main exam. Okay, so until proven otherwise, I think question also has some problem. So final answer is we are going with the C. Okay, understand the concept, Dr. Vargab. Understand the concept, not about the answer, and you will get this question directly. You decide few things when you get into the exam hall. So if you see in the Davidson, there is a chart given. In that chart, like a lot of type of findings given: pneumothorax finding, pleural effusion finding, consolidation or pneumonia finding. So that chart must, please take as home task, must see that chart, right? So in this one, we're choosing left flow of consolidation after discussion. Next one, patient with cut to the wrist and inability to flex the distal phalanx of the little finger. What is damaged? I think it's a straightforward question. Straightforward question. It's a flexor digitorum profundus. Flexor digitorum profundus. So some of the things like that nerve and muscles might be tested, including the brachial plexus, so which you really need to read well. So brachial plexus and some of these nerve and muscles could be tested. So we don't have that much to do with this type of question. Nothing actually concept to apply in that way. 18 years old with deterioration, confusion, widespread petechial rash and meningitis. So this is a case with meningitis with rash. So it can be Neisseria meningitis. Remember one thing, meningitis with rash, always it can be Neisseria meningitis. And blood pressure is like this, you can see. So a meningitis case which is deteriorating. So case of meningitis which is also deteriorating. And pulse, uprise pulse. So what to do? I think without any delay, I think we should, if we have offered blood culture, we can go for that one probably. But thing is, this is Neisseria meningitis. Even if you offered blood culture, we won't go for blood culture here. Neisseria meningitis is deadly. Without any delay, you give a broad spectrum IV antibiotic. Okay, so our answer is ceftriaxone. Ceftriaxone. According to the books, it's ceftriaxone. So suspected meningitis, there's actually two versions of this question. Usual cases, we do blood culture except for Neisseria meningitis. In Neisseria meningitis, without delay, we can go for directly antibiotic. Okay. So little correction here. Yeah, it's usually given, can be given. But in any ways, the ceftriaxone is coming. But in any ways, ceftriaxone is coming, as you can see, and I just highlighted that one. Yes. Young with Duchenne muscular dystrophy, you can understand this is something related to muscle. They have an interesting sign of standing up that is called the Gower sign. Have you ever seen a case of Duchenne muscular dystrophy? Very interesting way they get up. If you have never seen, you just Google it next day. So parents want to know the chances of second child being affected. So Duchenne muscular dystrophy, guys. Okay. It's a genetic disease, no doubt. Let me show you. So first of all, if you see here, it's a X-linked. It's a X-linked. And one baby is already affected. So what do you think? What we should do next? Okay. So basically, since X-linked, I think we should go with the 50% for this one. Since it's considered, X-linked, so I think it can be the 50% in my mind. All right. So not this one. It should be this one. All right. So this one to remember. 50% usually affected. Also try to know about the schizophrenia, like this kind of percentage often also tested. Do you know that one, guys? I won't get into that one in that case. Do you know the schizophrenia percentage? Something you have to tell yes, no, yes, no. So schizophrenia percentage, if you want to see, please take a picture on that one. Schizophrenia, they might ask you what is the percentage of having both parents affected? What is the percentage of having monozygotic twin affected? Okay, what is the percentage of sibling affected? So please keep it in mind. Yeah, so question and things can be little different. So this one to remember. Parents, both parents, sibling, monozygotic twins. All right. Okay, 45-year woman whose cervical smear revealed moderate dyskaryocytosis. So what to do next? Moderate. Moderate means which one? CIN1, CIN2, CIN3. Are you clear with this one? Moderate means this one. Now which one we think low grade and which one we think high grade? This one we consider low grade. This one we consider high grade. This one we consider high grade. And high grade, without any second thought, we should go for colposcopy. So you go for colposcopy. So A is the correct answer. Sometimes some of the question might also come regarding vaginal discharge. This is the extra thing, could be useful. A lot of question we have seen sometimes came with vaginal discharge. So it's a nice table to be, but I think apart from this one, I think this one is even more, I think, interesting. So vaginal discharge, this thing, vaginal discharge, this thing. We discussed in our regular theory classes, but I still, because this is so common in the exams. So vaginal discharge can be presented with white card-like. So candida, foul smelly one, bacterial vaginosis or trichomonas, but strawberry appearance of the vagina, trichomonas. If mentioned wet mount preparation or clue cell, again bacterial vaginosis. Sometimes they might mention about the color. So gray color, bacterial vaginosis. Sometimes vaginal discharge, history of exposure, UCD, and special point is cervical motion tenderness. Those are using mobile, you might find it very small, which is displayed right now. But the laptop people are fine, I'm sure. So we are talking about the PID, pelvic inflammatory disease. Remember one thing, pelvic inflammatory disease, what could be the cause of PID? Two organism, they're like brothers. I sometimes said in that way in regular classes, the two puppy actually. One is the chlamydia and one is the gonorrhea. No, that's different. Ectopic is different. One is chlamydia and it's the gonorrhea. So if you ever treating a case of PID, give a treatment for both. Treatment for both. All right. So because another one can be hidden. Just remember this. So main cause of PID, it's often mixed. Okay. 48. A review of 65-year-old has post-rectal cancer, indwelling catheter. I think again a catheter related question. Likely cause of aneurysm. This time, totally, stopped. What could be the reason? Without any delay, if you give answer, reason of aneurysm. There's a surgery done, suddenly aneurysm. It's not a very tough one. Or not acute kidney injury. That's not the answer. I think again a practical question, guys. You should check the block first. I think you should, this is a practical question, guys. I think many of you might lacking the practical experiences. Suddenly thing is happening. The likely one you should consider is check the catheter whether blocked, why the output is not coming. So this is the most important thing to do. So catheter blockage, then you consider some other thing. If injury to the bladder ureter, there will be a lot of blood and things will come. Nothing mentioned like. Okay, last two questions. 45-year woman who had 4 episodes of palpitation, wearing hyperventilation tachycardia for 1 month. What is the most likely diagnosis? Feeling she's lost her life, worried about a month, palpitation, most importantly, palpitation 4 episode, hyperventilation. My diagnosis, I made it already. So this is most likely case of, yes, panic. Palpitation is present, also hyperventilation. So it's high likely panic disorder. Okay. Dr. Muktadi, you have to study a little bit more. I think a lot of the answer I just was checking, you were missing actually compared to other. Okay, so I think a little bit more reading I would appreciate. Okay, all right. It's okay. It's better to know that since you have time, it's okay. You can keep revising things a little bit more. Those videos in our regular classes, I think I request you to see them much more. It will be better. You have a lot of time still, so you can cover up actually. Okay, they have exam in March, so they're more correct probably. But some of the other June is also studying more, maybe correcting more. Okay, but so later rather than regretting, it's better we know now and correct it immediately. All right, great. Okay, and again a word. See, number of numbers related question often comes. I also hate it, but it's okay. Sometimes we need to know. So, guys, one suggestion for you: those are genetic things, like those are autosomal dependent, dominant, autosomal recessive, and X-linked. At least know the names and at least know the percentage. Like autosomal dominant, 50% chances of affecting. Recessive, 25. And here is also like 50. So, anyways, so you just remember that one autosomal neurofibromatosis. This is runs in the family, so this is autosomal dominant. If autosomal dominant, the answer would be this one, C. So neurofibromatosis. Tell me one um, ENT related problem with neurofibromatosis before I finish, because that one I also found in the exam. Tell me one neurofibromatosis related problem which is related to ENT. Neurofibromatosis type 1, type 2. There's two type. Let's see who at least know the answer. So one of the problem, almost there. Yes, hearing loss. Yes, hearing loss. But what is the diagnosis? You are almost there. Two of the doctors are almost there. Yes, someone is correct actually. Yeah, sensory neural deafness, but the number one cause is, let me show you. So neurofibromatosis. Yeah, they will give you a lesion like this. Cafe au lait spot. And yes, here is this one. NF1 and NF2. Sorry, let me show it again. Yes. NF1, cafe au lait spot and glioma, but NF2, bilateral acoustic neuroma. So of course, associated with hearing loss, sensory neural hearing loss. Wonderful job, guys. So I'm also feeling good that you guys are doing good. So it can be associated. So this question often they try to test in the main exam. So this is how the association thing they try to make. Okay, so this is acoustic neuroma. All right. Now, first of all, thank you for attending. Now you have to do a few job. So this is the end of first session. Second session will be getting tomorrow. Will be a little bit more first, and a lot of question will be repeated. Yeah. So a lot of things would be repeated next day. It will be much more easier, I believe, for all of you. Don't worry, even if it is necessary, we'll be helping you with a lot of things.